everyone. Japan is now at 3 p.m. So thank you very much for joining and support the ACNS educational program. So later, I think we can expect another host, Dr. Kalangu, Jacobi, and also the Dr. Kreshi. So today's moderator is Pablo. He used to be our good fellow. And also the Tango. Tango is with us now or not yet? Not yet. And also discussant is Conan and Professor Alexander Bosniak from Ukraine, and also the opera from Nigeria. So then, so this is some educational purpose for maybe having some progression of the African education, especially the direct surgery. So hope the African young colleagues can enjoy, and maybe we can have a good discussion among us. And the first speaker is Yamamoto Sensei. Now the Yamamoto Sensei is the first speaker. Maybe I think you can introduce yourself a bit. He's a great functional neurosurgeon in Japan, very famous in the nation and outside of Japan.
Okay. Yeah. Hi everyone. I'm Taka Yamamoto from Japan, and when I started the neurosurgical career, I was doing almost everything, including aneurysm surgery and the brain surgery. But I changed my mind and went into functional, specialized in epilepsy around in 2000. So now I only do functional, particularly epilepsy surgery. Okay, may I start my presentation?
Yes, Professor.
Okay. Can you hear me?
Yes.
Okay. So I am going to talk about the basics in temporal lobe surgery. There's no relevant COI in this presentation. This is headlines. I'm going to talk about the basic concepts in epilepsy surgery, and anatomy of the temporal lobe, and a step-by-step hippocampectomy. So first of all, I'll show you these changes in terminology by ILA, International League Against Epilepsy. We previously called a simple passive seizure SPS. Now it is called a focal onset aware seizures, FAS. In complex partial seizure, CPS, it is now called the focal onset impaired awareness seizures, FIS or FIS. And secondary generalization is now called the focal to bilateral tonic-clonic seizures, FBTCS. So this is sometimes give us confusion, but now we at the present we normally call FAS, FIAS, FBTCS. And I will talk about epilepsy, temporal lobe surgery today, and that includes these terminology. So first of all, indications for epilepsy surgery. That is definition of a medical refractory epilepsy. And normally we say appropriate 2 drugs for 2 years. What is appropriate? If you choose phenobarbital or clonazepam for refractory localized epilepsy with the focal onset impaired awareness seizures, it will be inappropriate to control seizures. Carbamazepine, lamotrigine, levetiracetam, or other newer anti-seizure medications. So if these are available in your country, should be prescribed. In a definition by ILAE, that is a failure to achieve seizure freedom with the 2 appropriately used anti-epileptic drugs as monotherapies or combinations for 1 year or 3 times the longest prior seizure-free interval needs further evaluations for surgery.
まだね、これだけしてるホストなんですけど、なってるね、これ。まだ5人入ってないんですよ。
Can I continue?
Yes.
Yes. And this slide shows the seizure freedom by the number of anti-epileptic drugs. So with the first anti-epileptic drugs, we can get the achievement of seizure freedom about 50% of patients. And then with the second drug, it going to be around 6% or more. And then the third drug, that will be 70%. And then with more drugs, the control of seizures getting more and more difficult. So this is a pre-surgical evaluations. We normally do EEG at the clinic, neuroimaging including MRI, and higher brain functions such as IQ or memory function, and long-term video EEG monitoring. This is normally the patient should be hospitalized for a week to see habitual seizures. And MEG, if it is available, but it is not essential. And FDG PET and or SPECT, if it is available, better to, I think this is better to obtain these images. And the water testing to identify our language dominant hemisphere. So this is the phases in epilepsy surgery. Phase 1, long-term video EEG monitoring, as I told you in the previous slide. In the phase 2, intracranial electrodes and the invasive monitoring. In the phase 3, focal resection. But if focus is detected without invasive monitoring, then we can go directly to the phase 3. And then the second part, anatomy of the temporal lobe. There are different approaches to the hippocampus. So transcerebrium, so we divide cerebrium fissure and get into the inferior horn of the lateral ventricle, and transsulcus approach and the transgyral approach. This is simple and the most frequently used in our country and also worldwide. In the subtemporal approach, it's like here. So if we see in real anatomy, transcerebrium approach is like this here, from here to, and get into the ventricle. And the transsulcal approach is here. Oh, sorry. Transsulcal approach is here. And transgyral approach is like this. And the subtemporal approach is from here to here. And this is hippocampus in the ventricle, and we approach from here and get into the ventricle and resect the hippocampus anteriorly and posteriorly. And there are many important part of anatomy along the hippocampus. the midbrain and very important arteries and veins and also nerves here. So we should be careful when we resect the hippocampus. And this is a vascular anatomy of the hippocampus. This is a posterior cerebral artery, and the hippocampal arteries are like this here, and also veins. And it is a real anatomy. So we should be very careful about these serpentine arteries like this. If we injure these arteries, some sequelae, sometimes serious sequelae will be occur. So this is a temporal lobe surgery. Anteromedial temporal lobectomy. I usually use this approach, and this is created by Dr. Dennis Spencer, a very famous guy, and we resect the anterior part of the temporal lobe and get into the ventricle like this. And this is a preoperative MRI FLAIR image that shows, an actual image shows the hippocampus, atrophy of the right hippocampus like this, and the higher intensity of the hippocampus here and here. And this is the results from the long-term video EEG monitoring and the interictal EEG, bilateral temporal lobe, bilateral temporal spikes. This is the left side, and this is right side, but the predominant on the right temporal region, like this. And this is ictal EEG captured. We captured the 3 habitual seizures events and the rhythmic theta activity over the right temporal region. The same area of the spikes on the in the interictal phase. So this is the positioning. Their head turned to the other side, almost 180 degree, and we do. I do not like vertex down, just almost just flat. And the skin incision wrapped by the sponge like this. And this is the part of the temporal lobectomy. We are going to open the inferior horn of the temporal lateral ventricle. So we now go into the middle temporal gyrus, 3.5 centimeter from the tip of the temporal lobe. And continue the resection of the middle temporal lobe, and we can get into the ventricle here like this. We can see the hippocampus. So opening the temporal horn, tactics and pitfalls that keep suctioning in the white matter. If you get into the gray matter, stop suctioning. This is very dangerous, and reconsider where you are. And use navigation system if it is available. So we can directly to the ventricle. This is probably easiest way to get into the ventricle. And resection around the hippocampus. So this is the hippocampus like this. And we use 2 spatulas. And just in case we check the electrocardiogram from the hippocampus. And we resected the other part except the hippocampus. in the surface of the amygdala. This is amygdala. Surface of amygdala is coagulated and aspirated. And then we can accomplish anterior disconnection from between the amygdala and the hippocampus. So tactics and pitfalls: remove the inferior 2/3 of the amygdala and the uncus of the perihippocampus. Remove the perihippocampus gyrus as much as possible to make hippocampal resection easier. And hippocampectomy. And fimbria. This is the fimbria. The fimbria is also resected to see the arteries and the veins going into the hippocampus. So we needed at least a 2.5 centimeter from the tip. Then so we can see small arteries and veins here, and the coagulated and cut close to the hippocampus. So the hippocampus is almost isolated. So almost a 2.5 centimeter. It is necessary to control seizures. The small vessels such as the hippocampal artery from the posterior cerebral artery and the anterior choroidal arteries should be cauterized and then sharply divided only after they are well within the fissure. Do not cauterize the choroidal plexus because it may lead to thrombosis of the anterior choroidal artery. So if infection of occurred, the symptom is called anterior choroidal artery syndrome, including hemiplegia, hemianets, anesthesia, contralateral homonymous anopia. This is serious, but I had one case with a mild anterior choroidal artery syndrome. He had mild hemiplegia, but hemiparesis. But fortunately, he is now back to the normal, and there's no obvious hemiparesis. The final stage, additional resection. So more resection of the uncus, and I put surgical cell here. And then we need a more resection of the hippocampus, 1 more centimeter. And also clean up the residual parahippocampal gyrus. And put the surgical cell and finish the surgery. So clean up the residual parahippocampal gyrus is also important. And additional resection of the residual hippocampus tail never goes to superiorly because the tail is bordered superiorly by the pulvina of the thalamus, the internal capsule, and the tail of the chordate nucleus. In a post-operative MRI shows that the middle and the inferior temporal gyri were resected. And when we went into deeper structures, the hippocampus and the parahippocampal gyrus were rejected here, like this. This is a very famous article published by Dr. Weeb in Canada. Was published in 2001, and that shows that the epilepsy surgery of the temporal lobe is more efficacious than drug treatment. And level 1, class 1 evidence was awarded from the American Academy of Neurology and American Epilepsy Society. Take home, the basic concepts including the definition of medically refractory epilepsy and indications of epilepsy surgery were presented. Patients with temporal lobe epilepsy are seen most frequently at an outpatient clinic. Temporal lobe surgery, such as anteromedial temporal lobectomy, is performed worldwide. And the first hurdle for young neurosurgeons specialized in epilepsy. And I think many patients with the temporal lobe epilepsy seen in African countries, I think. So this procedure is very important for young neurosurgeons. Thank you very much for your attention.
Thank you, Professor Yamamoto.
Yes.
Dr. Liu, do we want to have questions now or later?
Maybe now we have Kazari Kalangu, one of the hosts for today's webinar. Kazari Sensei, konnichiwa.
Thank you very much. Thank you very much.
Maybe as one of the hosts.
Kato Sensei.
Kazari Sensei. Dozo.
Hello, can you hear me?
Of course, yes. We can hear.
Thank you very much. Morning, everyone. Sorry for the delay. I had a bit of difficulties to connect, but that's done. Would you like me to make a comment?
Yes, no, you want to say something as an opening remark?
Absolutely. Once again, thank you very much for all the invited guests who are coming to share their knowledge with us. And this is in line of training our young neurosurgeons so that our experience as grown-up neurosurgeons, experienced neurosurgeons can go to the young neurosurgeons. And this initiative of the ACNS, which is excellent, because that's the only way we can pass to our younger colleagues the knowledge from the more experienced neurosurgeons. So congratulations to all the organizers. And this is really something to emulate and to continue to do regularly, the way you are doing it in any way. Thank you.
Thank you very much. No, Sensei, ごめんなさい. Amira, please continue.
Yes, Professor Kato. Should we have the discussion now for Professor Yamamoto? Yes, I would like to invite Professor Wozniak for a few comments.
Okay. Professor, thank you very much. Professor Yamamoto, thank you very much for a great lecture. You simplified the problem as much as it's possible, and it's very good for our young colleagues, and everything was explained clearly. I want to comment to go on with your idea that if the surgeon starts to operate epilepsy, it's better to start from temporal. And the key point of this problem is the selection of patients. If only properly selected patient will have a very good result. So, and I insist also, I want to repeat it once again, that it's better to start from the temporal epilepsy. But I have a question to Professor Yamamoto. When you plan the amygdala hippocampectomy, do you prefer to resect the temporal pole as well, or you prefer to perform the selective procedure. So one,
Uh,
and when we speak about left side hypocamp, do you test the memory of the patient? Because you know the undesirable complication is the amnestic syndrome after left side, after dominant hippocampectomy. Do you perform some testing of these patients? Thank you.
Yeah. Thank you, Alexander. I prefer to reject including pole over temporal lobe.
Yes.
Because sometimes some focus is located on the temporal pole, except hippocampus only. Then sometimes patients who underwent selective amygdala hippocampectomy had residual seizures because of the other side, outside of the temporal lobe is remain. Now I prefer anteromedial temporal lobectomy, including the temporal pole. And the second question, the left side, the language dominant hemisphere of in temporal lobe. WMS memory testing is very important to select the patients who is the candidate for left-sided resection. If a patient's memory is under 60, then we can perform left temporal resection, but more than 70 or 80, we cannot. Then we should consider the other type of procedures or other medications. Thank you.
Okay. Thank you. Thank you very much. Thank you for great talk. Thank you.
Maybe I think Amira,
Yes.
some question to him?
No, I think that's a very good presentation. And for epilepsy surgery, I think anatomy of the temporal lobe is the most important, especially the hippocampus and the amygdala, because you know, the fiber tracts that come in those relations, if you avoid injury, especially the Mayer's loop, which is in the lateral wall and the roof, if you can, you know, avoid injury, think you can do a very good job and a more complete, you know, removal of the focus and give good seizure freedom. Thank you very much for your presentation, Dr. Yamamoto.
Thank you.
Can I ask Yamamoto Sensei?
Hi.
Sensei, domo arigatou gozaimashita. Thank you very much. A great lecture.
Thank you.
And just I will ask the future direction of the epileptic treatments, epilepsy treatments. So how do you think? So because so many nice drug. So every month the new drug is coming up, and also less invasive treatments for epileptic surgery. So how do you think?
Yeah, it's probably these resection surgery will be replaced by the devices and also drugs, as you said, are very good to treat patients, and more and more patients will be seizure free with these new drugs. So the future of epilepsy surgery will be changed dramatically in 10 years and 20 years.
Thank you. Maybe Dr. Yashin from Algeria.
Hi, everyone.
Konnichiwa.
Thank you, Professor, for your presentation. I have two questions. My first question about neuronavigation. Did you use the neuronavigation for your resection or just anatomical landmark? And the second question about the medial limit in the resection. What is the medial limit resection in the amygdalo-hippocampectomy? Thank you.
The first question is navigation system, right?
Yes.
Normally, use navigation system, but the approach I showed you is very simple to find directly to the ventricle, to find the inferior horn of the lateral ventricle. If we can find the lateral ventricle, the surgery is the same, almost the same every time. Then it is not necessary to use the navigation system. And the second question is limitation of resection.
Especially the medial.
Medial.
Mm.
Medial side of the hippocampus.
Yes.
You mean? Hippocampus is completely resected, adjacent to the choroidal plexus, including the fimbria and the parahippocampal gyrus. And from the 2 centimeter or 3 centimeter from the tip of the hippocampus will be removed.
Okay, thank you, Professor.
Dr. Sara has a question.
Yes, thank you very much, Professor Yamamoto.
Yes.
So I work in Australia, and I just wanted to see how easy it is to get access to epilepsy surgery in Japan and some of the other countries. I found it extraordinarily difficult to set up epilepsy unit in Queensland. The hospitals saw it as expensive. I have done it. One of my trainees is doing it now, and he's doing SEEGs, and we've started doing LIT, but it runs at a loss. And so hospitals really, at least in Australia, put up quite a few barriers to us starting up epilepsy units, and we have a great need for it. Is that the same in Japan?
Yeah, same. Everything is very expensive. Then we want to introduce Rosa as a robot for stereotactic EEG, but it is still expensive for us, and then we're just now preparing. But also EEG machine for video EEG monitoring is also expensive. Then yeah, it's the same situation in your country as in your country.
Oh. Thank you.
Kazadi?
Thank you very much. Congratulations, Professor Yamamoto, for your presentation. I saw only the second part and the summary, of course. Thank you very much. That's very elegant operation. I'm a bit concerned about, first of all, of the cost availability of this kind of surgery in our areas, our countries in Africa, and also the fact that it's a bit destructive because you have to go and remove part of the brain. Of course, I mean the results are very good. The life of the patient is improved. Now, my question is, have you considered or you heard about cannabis oil treatment on epilepsy?
What kind of a treatment? May I ask you once again?
With cannabis oil. Cannabis.
Cannabis. It is, the drug is just the clinical trial is just finished, I think, in my country, and I never used the medication yet. Sorry, this is not the appropriate answer to you.
Okay. Thank you very much.
Should we move ahead, Professor Kato?
Yes, I think so. Yes.
Okay. I would like to now invite with pleasure Professor Kato for her talk, and she will be talking on recent treatment in aneurysm surgery.
Or maybe I sent the recorded video.
Okay. Dr. Liu?
Yeah.
of the surgical clipping for cerebral aneurysm. Once again, I thank you very much. When we organized this web seminar, Nigeria to Senegal collaboration, I thank you very much, Professor Kazadi Kanangu, and also the Timothy Shakombi, and also the Mohammed Kresh. Those are one of the best friends in Africa. So it's a time of the endovascular era. So, but even though that we need some open surgery or sometimes bypass, additional tool for the case. So this is the role of the surgical clipping for cerebral aneurysm complex cerebral aneurysm. Such as we can do open surgery for treating of the cerebral aneurysm is place occupying ICH and MCA and pericallosal aneurysm location and blister type aneurysm or unfavorable anatomical neck coiling, failed endovascular treatment, the wide neck aneurysm. After the coiled aneurysm, incomplete ovulation, subsequent growth of the residual neck or dome, increasing of the coil mass effect, young age, and the good clinical grading. So, of course, we should learn the open surgery. The English they can perform. So I meet the neurosurgeon. So maybe I think that the later that we do again, or maybe you can proceed. The next one.
Okay, Professor. The next one is me, I think.
Yes.
Should I start?
So everybody knows her. So she's very famous now. And I know her since she is from very young time getting the famous. And she worked so hard. And maybe I think one of the best lady neurosurgeon who knows the brain anatomical things, I think.
Thank you,
Please.
Dato. And I thank you for this invitation and holding this wonderful webinar. And my topic today, please excuse my voice, it is a little bit sore. So today I'm going to be talking on white matter anatomy relevant to functional neurosurgery. Why should neurosurgeons know about white matter? Because white matter matters. And as you will see in my presentation now. So this is how we know the brain sitting on the skull base. This is the dura. Once you open the dura, you see the naked brain with all the vascular structures. This is what we all know as skull-based surgeons, and this is what we deal with, with the vessels going in the arachnoid and all the structures. But how many times do we just look at the brain without all the vasculature, with the, just the gyri and the sulci, just the cortical and the subcortical anatomy, and how important and relevant it is for all our interaxial brain surgeries, for all epilepsy surgeries, for all disconnections. It is very important to know both the cortical and the subcortical anatomy of the brain. So earlier there were, we used to think of the brain as having cortical areas of eloquence. Typically they used to be called as the Broca's area and the Wernicke's area. And how has our understanding has increased, it is realized that both the cortex and the underlying subcortical white matter, both are important for function. Suppose you damage a cortical area, there might be some other area that might take up that function and the patient will, improve with plasticity. But if you cut the subcortical area, so it is like an electrical grid. If you cut the wires, you cannot, get back the wires. You cannot regain that function. So it is important to look at each function of the brain as a connectome. So like if you see for language, there are two main pathways. That is the semantic pathway and that is the ventral pathway, and the phonologic pathway or the dorsal pathway. So you look at it as substrates. So then there are some cortical substrates like the superior temporal gyrus, the middle temporal gyrus, the dorsolateral prefrontal cortex.
いや、カブロさんが喋るのであれば、なんかそのタイミングが取りたいなと。
Then, and the main fiber system that conveys this pathway is the IFOF, and also the other ones are the inferior longitudinal fasciculus and the uncinate. So if you damage this, the dominant area, you will get semantic paraphasias, and in the non-dominant area, you will get non-verbal comprehension disorders. Similarly, there is the phonologic pathway or the articulation pathway. In that, you have the inferior frontal gyrus, the middle and the superior temporal gyrus, and the arcuate fasciculus is the direct pathway in that. And the SLF is the indirect pathway that is part of the whole dorsal pathway of language. So you can see in this image, the arcuate fasciculus, the SLF3, that is part of this pathway. So now, my interest in white fibers started a long time ago. After doing it for many, many years, I came to an understanding of the architecture of the white fibers. And that is, I have a three-dimensional architecture in my head, and that helps me a lot during this interaction brain surgery. And that is what I'm trying to present to you. So I've divided the white fibers of the brain into these 5 groups. So there are 4 horizontal layers. So the first one here is the short arcuate fibers or the superficial group. The second one here is the middle layer or long association fibers. The third one here is the deep group that is in association in close relation with the ventricles. And then in between you have the central group or the commissural fibers. And the vertical group is the projection fibers. So if you see in these tractographic images, you see this blue structure here is the vertical fibers, projection fibers as they run from cranial to caudal. So there are fibers on medial side of it and on lateral side of it. Fibers which are on medial remain medial to this vertical group, and fibers which are lateral remain lateral to this vertical group of fibers. And this red structure here are the commissural fibers. So I'll just show you some images and then I will go into the functional aspects or how we relate it to neurosurgery. So once you remove the gray matter on the top of the brain and within the sulci, you see the short arcuate fibers here as they connect various areas to each other. Now this is a 7 Tesla MRI image, and you can see how innumerable these short arcuate connections are and how intricately they're connecting adjacent areas of the brain to each other. So once I remove the short arcuate fibers, you see these fibers here. This is the SLF, the lateral part of the SLF or the SLF2 and 3. So here you see these are the short arcuate or the U fibers. This is the SLF. And then this structure that is curving around here is the arcuate fasciculus. This one that is running down here is the ILF. And just beneath it is the middle longitudinal fasciculus. Now, once I open the sylvian fissure, the cortex that I see here is the insular cortex or the hidden lobe of the brain. And around it, there are a lot of fibers that are important. So again, I'm showing you, this is the SLF, this is the arcuate, this is the middle longitudinal fasciculus, this is the inferior longitudinal fasciculus. Now I've removed the gray matter of the insula, and the first one that you see here is the extreme capsule. Once I remove the extreme capsule and the claustrum, these are the fibers that come in the picture. This one here is the IFOF. This one here is the uncinate fasciculus. Down below is the ILF. And now you can see the arcuate fasciculus more clearly. On top here is the SLF. These are fibers of the external capsule as they go and meet the internal capsule to form the corona radiata. Now I've lifted the arcuate fasciculus up, and you can see the occipital part of the IFOF as it is going into the occipital lobe. Here you can see I've started removing some gray matter here. This is the dorsal part of the external capsule. This is the ventral part of the external capsule. Now removing more, you remove the IFOF and you see these fibers. These are fibers of the optic radiations that are going all the way to the occipital lobe. I've cut the arcuate fasciculus here. And here I've removed the putamen. And you can see the beginning of the internal capsule here. Just again to show you, this is the extreme capsule. This is the external claustrum. And just beneath that will be the external capsule. So this thin layer that you see here is the claustrum. And this first one is the extreme capsule. And the fibers that are starting just beneath it is the dorsal part of the external capsule. So here again, another image showing the same. Now you see the putamen. So the putamen lies between the external and the internal capsule. So the external and the internal capsules are capsules of the putamen. And now I've removed the putamen completely, and you start seeing the internal capsule in this region. So once again, this is the arcuate, this is the IFOF, and this is the internal capsule. Now you can see the internal capsule, the anterior limb, the genu, the posterior limb, and the sublentiform part of the internal capsule. Here, this structure that you see here is the anterior commissure. I cannot go into details of it now for lack of time, maybe later. So these are the fibers of the IFOF, these are fibers of the anterior commissure and fibers of the optic radiation. All of them come together in one big bundle that is called as the sagittal stratum. And this whole layer that you see here is that of the internal capsule, which you can see here dissected beautifully. So this is the anterior limb, this is the genu, this is the posterior limb, the retrolentiform part, and the sublentiform part of the internal capsule. All these relations are important when you're performing certain surgeries. And let me see if I can show you. So these are the fiber bundles that are most important, or the major fiber bundles in the brain. And these are the deficits that may occur due to damage to these fiber bundles. So they're not exactly, you cannot damage these fiber bundles because these are huge deficits. So just to show you in a pictorial image. So if you see, if you cause and stimulation here in the SLF region and in the arcuate fasciculus region, you'll get speech arrest and dysarthria. When you do it here, you get repetition areas and phonological paraphasias. When you do it in the region of the IFOF, you'll get syntactical errors or semantic paraphasias. So these are various fiber bundles, and these are the problems that can occur. Now, based on these fiber bundles, it has changed our understanding of glioma surgery. Now, we believe that gliomas are confined to one named white fiber tract, and it displaces the other normal fiber tracts along it, around it. So you have to identify the fiber tract that it originates from and then tackle the tumor accordingly. So if it arises from the short arcuate fibers, they are quite localized. They remain confined to a gyrus, and I like to call them localized group of gliomas. If they arise from long association fibers, they follow this track of the long association fibers. So this is the cingulum, and you see it is going up here. So the glioma will also follow this track of the cingulum, and I'd like to call them as diffuse type. If you think of corpus callosal gliomas, generally they are bilateral and they follow the radiations of the corpus callosum. And this is also another diffuse type of glioma. So based on this understanding, for gliomas that originate from the short arcuate fibers, you can use this en masse tumor resection, that you can identify the short arcuate fiber that it is related to and remove the tumor completely. So if you look at this tumor, it is arising from the short arcuate fibers in the region of the superior frontal gyrus. And cortically, this area is also known as the supplementary motor area. So this is the anatomical picture that shows the supplementary motor area. And these are the white fibers that are displaced posteriorly. This is the projection fibers of the corticospinal tract. And this is our tumor removal strategy. We used to use mapping in majority of the patients earlier, but now our need for mapping has reduced because of the anatomical understanding. So on opening the dura, you identify the tumor based on its, you can use neuronavigation or you can use sonography. You can identify the anterior, posterior extent of the tumor. And then basically we go around the whole tumor, around the short arcuate fibers that the tumor has arisen from, and then remove it en masse, as you can see in this image here. And this plane is very beautifully identifiable during surgery. You can make from the consistency of the tumor, from the visual impression, you can get this plane beautifully. And once you go around this tumor, you can get a very good radical resection. Now you see here that you can make out very easily the normal from the abnormal. Below here is the white matter that is normal. And you can also feel the plane that is there around the tumor. And you can go ahead and do an en masse resection and remove the tumor. This strategy also, lowers your injury to the vasculature, because, you're not going through any vasculature. You're going around the tumor and you can preserve the vessels. And you can see here this normal structure that is there. You can see it at the end of the resection cavity. This is the whole tumor that has been removed. And this is the normal white matter that is present here. And using this surgical strategy, we can get a very good radical resection. Here you see the MEPs are preserved And you can see that we've gone around and quite well removed the tumor. We can also use this tumor resection because of the anatomical knowledge, even in eloquent areas. Now, if you see this area, this is the inferior frontal gyrus, the pars opercularis region, which might be, tricky on the left side. This patient that we wanted to operate refused, was not cooperative at all for an awake craniotomy. And we did perform this surgery using navigation help and also our anatomical knowledge. And you can see that we've used an en masse resection strategy even in this case. And you can see the surgery. And you can see that you can make out this is an abnormal part. This is the normal part. So we've gone around the tumor even in such a patient, even in such an eloquent area, because we are so sure of the anatomical knowledge. And here you see this is the normal, this is the abnormal. And we are removing the tumor, preserving all the vessels. And you can see at the end, all the vessels are preserved. This is at the end of resection. The resection cavity, the whole tumor being removed. This is the DTI at the end of tumor resection, which is preserved, and this is the patient. It is in an Indian language, but you can see he's speaking. This is on day 2. Day 1 actually. And just mild dysarthria, but he did very well. Coming to insular gliomas, you can see that this is an interesting case. So if you see this anatomical picture, this is the pars opercularis. And the whole tumor is in this region. It's in the pars opercularis of the inferior frontal gyrus. And you can see how with this strategy I've removed it. So this is the intra-op ultrasound before tumor resection, and this is the ultrasound after tumor resection. And you can see I've removed the whole tumor exactly in this shape. And this is the post-op scan. And this is the size of the tumor. And this patient also did very well without any speech deficits. This is some insular gliomas. I don't have the time to go into details, but this is the pre-op and the post-op radical resection that has been performed. Coming to the medial aspect of the brain and the limbic system. So the medial aspect of the brain is related to the limbic system. So as I was showing you, this is the cingulum, and the cingulum generally tracks towards the parietal and the frontal cortex. So the tumors that arise from the cingulum also tend to go in this direction, or they may extend downwards. So this is the whole limbic system and the Papez circuit. Here you can see the hippocampus, the fimbria, the fornix, the columns of the fornix, the mammillary body, the mammillothalamic tract, the anterior nucleus of thalamus, the anterior thalamic radiations, and the cingulum coming back to end here in the temporal region. So this is the whole Papez circuit, and it is important to understand this Papez circuit and the limbic circuits for performing surgery in this area. And this is the whole Papez circuit that I have dissected outside. Here you can see the thalamic radiations, the anterior, superior, posterior, and inferior thalamic radiation dissected from medially. This was our paper on the subject. Based on this dissection, we've come to certain concepts of understanding. So if you see this is important for temporal lobe surgery. So if you see this IFOF and the optic radiation, the hippocampus here is related to the, in the temporal horn, the IFOF and the optic radiation. In the anterior part of the temporal horn, they are in the roof, and the posterior part, they are in the lateral wall. So there is an area here that is devoid of any fibers. And if you can enter the temporal horn in this region and then remain beneath this region, you will avoid injury to this. So this is our safe entry point, which we have described to enter the temporal horn and perform. We perform our epilepsy surgeries also like this. We go in and enter the temporal horn and then perform an en bloc resection of this whole area, including the amygdala and the hippocampus. And this technique has been described by Professor Goel. And this is our entry point. And this is our paper on the subject. So this is another tumor in the region of the cingulum. This is a limbic tumor. So how do you approach this tumor? You have to understand that it is originating from the isthmus of the cingulum. And the best way to get to this is without crossing any optic radiation or causing any injury is going interhemispheric. As you can see that I've done here and gone ahead and done a radical dissection of the tumor. These are some tumors of the medial temporal region. This is a region tumor of the amygdala. So again, we have approached this tumor to the middle temporal gyrus, remained beneath the roof of the temporal horn, and you can see that I've resected the tumor quite nicely. This again another tumor that is involving the amygdala and the hippocampus and the parahippocampal region. Again, you see this is the region of the tumor anatomically, and I've gone in and removed this from the middle temporal gyrus approach, and you can see the resection. Coming to the second last thing, the orbital cortical approach for deep lesions in the caudate head or in the lesions of the frontal horn. We've described two trajectories that comes from either the medial or the lateral, You can straight reach the frontal horn and the caudate head. This is an example. You can come from here. So you don't have to come contralaterally. You don't have to come interhemispheric. There's a straight trajectory here without causing any damage to the fibers. And this is the orbital cortical approach. Corpus callosum anatomy is another important, beautiful anatomy. It connects both the hemispheres, and these are the various radiations of the corpus callosum, dorsal callosal radiations, forceps minor or the anterior callosal radiation, forceps major or the posterior callosal radiation, and these are the ventral callosal radiation. And important is the corticectomy that can be performed, callosotomy that can be performed here. You should perform a transverse callosotomy because the fibers are running transverse and then displace the fibers. For a disconnection, you have to disconnect this area. Otherwise, you will have a residual epilepsy present. So this is our study on the subject. And also the corpus callosum gliomas, how they follow the corpus callosal fibers, and understanding of this anatomy helps during the surgery. As you can see, the post-op scan and the radical resection of the tumor. Lastly, coming to the brainstem, this is another beautiful subject, and the anatomy of the brainstem is absolutely intricate. You can see the white fibers in this area, and this dissection we have done and studied all the white fibers in this location and how it has helped us. We have divided the white fibers of the brain into these 3 zones, and this I will not be able to show you in this lecture, maybe in some other lecture. And based on these zones, we can identify the safe areas to enter into the brainstem. And based on this understanding, I described this lateral cerebral peduncle approach to ventrally placed intraaxial midbrain tumors. So you enter from the lateral part of the cerebral peduncle, which has temporopontine fibers, and you can easily do it via supracerebellar approach. Here you can see this is the 4th nerve. The incision is made here in the lateral part of the cerebral peduncle. In this is the trajectory, and this is the lesion that we've operated. This turned out to be an oculomotor schwannoma. I'll just show you one short glimpse of the video. So this is the 4th nerve. As you can see here, this is the ventral part of the brainstem which we are exploring. So this is the 4th nerve. This is the cerebral peduncle. This is the tent being cut so that we can enter the cerebral peduncle from laterally. This is the region of the cerebral peduncle. And here you can see we are making the corticectomy here in this region and entering. And we can go in and identify the tumor in this region. Here you see this is the cyst of the tumor that is being evacuated. And this is the solid portion of the tumor that has been removed. And here you can see that the tumor has been removed completely. This turned out to be an oculomotor schwannoma, and the patient did very well after the surgery. So this is the importance of studying white matter anatomy of the brain. And I would invite you to see my book that I published with Professor Kato as one of the editors. And she has helped me in publishing this book. Recently, it is now available. And always remember that anatomy is important for the surgery. And I thank you very much for your attention.
Thank you, Abida.
Thank you so much, Professor Abida Shah. Congratulations for this beautiful presentation. I always enjoy your lectures. So thank you so much. Just a reminder, Professor Abida Shah is an assistant professor of neurosurgery at GS Medical College and Kemo Hospital in Mumbai. So thank you so much, Professor. I think we'll get one discussant, Dr. May. Are you there?
Yes, I am. Hi, Kabulu.
Yeah. Yes, your comment about Professor's presentation.
Wow, a really amazing presentation, Professor Abida Shah. Thank you so much for the lecture. I learned a lot from it, and I think the key takeaway I could get from your lecture is anatomy. Know your anatomy. And I'm really amazed at the way you spoke about the white matter tracts and all of that. I still have a lot to learn with regards to that in tumor resection surgeries. With tumor surgeries, if it's not convexity meningiomas, I find it a little difficult being able to take out everything, especially when you don't have neuronavigation and all of that, which is the setting in which I practice. So I'm really excited to learn what you taught today, and I would want to learn more. I've gotten a picture of your book, so I'm going to go look for it so I can read more about it. Thank you.
Thank you so much, Dr. May.
Thank you.
Professor, I have a small question. How many time do you take from your busy schedule to do your dissection? A week. How often do you go in the lab?
I go at least maybe once a week, definitely.
Wow, that's great.
Here it used to be
Okay.
more. Earlier it used to be more, but now it's once a week.
Okay. Professor Oleksandr?
Yes, thank you very much,
Yes.
Professor Shah. Good to see you again. Thank you for a great presentation. Really impressive. The excellent specimen, good surgery, everything wise, everything clear. I would like to emphasize for our colleagues the knowing of the fibers inside of the white matter, for how much it's impossible for surgery of intracerebral tumors, and how much it's impossible for epilepsy surgery, because you know that epilepsy surgery is divided to the resection surgery and the disconnection surgery, especially in pediatrics patients. Functional hemispherectomy, colostomy are very effective in cases of intractable epilepsy. So, and I think your work and your publication will help very much to neurosurgeons in the world, all over the world, in understanding, in planning, and performing a successful surgery. So thank you very much, and my congratulations. Thank you.
Thank you, Professor.
Thank you so much, Professor. Any question from the audience?
Maybe Dr. Yashin?
Yes.
Yashin from Algeria?
Yes, Dr.
Thank you
Yassin.
for your presentation. I don't have a question, but a very informative presentation with anatomic knowledge. Thank you.
So, Abdisha, just I want to ask one question, because when you remove the lesion, such kind of the glioma, so of course the fiber dissection study is very, very important. But once we encounter, once we do the surgery, so of course we cannot see the fiber. So, but from your surgery, maybe sometimes it looks like a meningioma. So is it quite easy to demarcate of the border, the lesion? And,
yes, Professor Kato, as we are, especially for these superficial gliomas that are restricted to a single gyrus, and you know the short arcuate fibers that is in the gyrus, it is, we are seeing more and more. Maybe we never used to look at it like that, but now that we are looking at it like this, we are able to get this plane. And in the beginning, if you have some difficulty, we use a sonography. So the sonography gives you exactly the anterior and the posterior margin and the medial and lateral margin. So, you know, you can make your corticectomy or your first incision around that margin and then go about. And, you know, with the feel of your instruments, you can make out from the difference between the normal and abnormal consistency. So yes, it is a lot of these tumors we are removing like this now.
And also, can you see in the naked eye or under the microscope some the glioma part and the normal brain?
Can I see? I didn't.
Can we see the some difference, the pathology part and also the normal brain?
Yes, you can make out the difference. You can make out once you with experience you can make out. And this white fiber dissection helps you in what way? Because when you're doing the fiber dissection, you start understanding at how much depth the long association fibers come. So with your instruments, with your feel. So even if you don't see the tracks, you know that at this depth this will come. So you automatically start becoming careful. That is the way how this dissection helps us.
Thank you very much.
Professor Shah, when you do your internal debulking, does it come easily? Does it detach easily from normal brain, or you make any effort to detach it?
It detaches with your suction. We normally use the suction as a dissector, but I think it's very easy. It does not bleed, nothing. It is a very nice plane that you can just remove.
Thank you so much, Professor. Last question for Professor Abidasha. If there is no question, I want to acknowledge the presence of my boss, the chair of Young African Neurosurgeon Forum, Dr. Ngobile. Dr. Ngobile, are you there?
Hi, hello.
Yes.
There's been great talks, and we've had Dr. Professor Bidashaw in our last webinar.
Thank
So,
you.
hello, greetings. Thank you.
Hello.
Thank you so much. So the next speaker.
Next one is Dr. Kabulo. Maybe the NHK broadcast is waiting for your report about your first clipping after you came back from Japan. Yes.
Thank you so much, Professor.
Yes, edited video. Just you can
okay.
tell us.
Let me do it in 2 minutes.
Maybe
Thank you, Professor.
Maybe the first one in your country clipping.
Yeah. So I'm Kabulo, neurosurgeon in Lubumbashi, Democratic Republic of Congo, a country with more than 100 million population, but we are only 19 permanent neurosurgeons. So I trained in Zimbabwe under Professor Kalangu, who is with us today, and I greet. So I did my fellowship in cerebrovascular surgery with under Professor Yoko Kato, a great teacher who taught me many things, and I finished 2 months ago. So I came back to Congo, and in Congo, so I had my first clip, which was like the first one clipped by a permanent Congolese neurosurgeon. Of course, Professor Kalangu does it in Zimbabwe, but as a permanent neurosurgeon in Congo was the first one. It was in the capital city. Unfortunately, my microscope doesn't have a recorder, so I could not record the operation. I have some pictures. It was a PCOM aneurysm in 65-year-old female who presented with severe headache, and the Glasgow Coma score was 11. CT scan showed subarachnoid hemorrhage. Then I took the patient to theater. This was the positioning. I did my craniotomy, and the brain was swollen. You can see it's red everywhere. This is subarachnoid hemorrhage. Then I did my arachnoid dissection slowly. Since it was like you are starting with the ruptured one instead of starting with the normal one. It was a big challenge. So after arachnoid dissection, that's the part I was trying to suck the blood, and I clipped. Unfortunately, there is no video at the moment I was clipping. The good thing is the patient went from 11 over 15 Glasgow Coma score before operation, and this was day 2 post-op. The patient could talk, could stand and walk, as you can see. So, and now the patient was discharged from the hospital. The patient is doing well at home. Thank you so much, and thank you again to Professor Kato for training us. Thank you.
My very much congratulations to your achievement. I think it's quite difficult because it's such a huge edema.
Yes.
Even though you dissected Sylvian fissure and reached to the skull base. My congratulations.
Thank you so much, Professor. Thank you. Prof. Kalangu?
Yes, thank you very much. I will be very short. First of all, thank you very much again, Professor Kokato, for giving us, and particularly to Dr. Kabulo, this opportunity to learn how to do vascular surgery. So our dream is to create a vascular unit where it can be done initially in Lubumbashi, but as you know, it's not easy to transport patients from other countries because Congo is huge. The distance between capital city and Lubumbashi is 2,000 kilometers. So it will be difficult to move patients, but surgeons can move and go and operate patients. But we are also planning to train other neurosurgeons in Congo, but of course also from other countries to come and learn so that we can afford to do this kind of surgery. The next thing I wanted to say, congratulations to Professor Abida Shah for this wonderful presentation, which I enjoyed a lot. And I'm sure we'll be able to invite her hello, Professor Shah. We'll invite you to Africa to do some
I'll be happy to go.
some safari into the brain. We have that, and really safari, of course. I think for young neurosurgeons, it's very good to see somebody first work on the cadavers to see, and also to emphasize the importance of knowledge of functional anatomy, not just anatomy, functional anatomy. And that's the difference, that's a big difference between a neurologist and neurosurgeon. I hope there is no neurologist between us. Okay, thank you very much again. Thank you.
Thank you so much, Professor.
So, yes. Carlo, so
yes, Prof.
So, do you supposed to receive some recorded system in the near future?
Yeah, I ordered, and I'm not sure. I think Professor Kalangu is traveling soon. I think with his help, if we can get it very soon, but I'm not sure when. But 3 weeks, 4 weeks, yeah. But if we get it, it will be very good.
Thank you.
Okay.
So.
Okay, thank you so much, Professor. So that was a PCOM aneurysm, and I always contact Professor Kato. I had another one, giant one, to do next time, but I'm still waiting for advice from my mentor, Professor Kato. Thank you so much. So I would like to ask Dr. Ngobile, my boss, to introduce the next speaker, Professor Oleg Sand, about insular glioma. Yes.
Yes, Professor Kabula, can I leave it to you to please introduce, because I'm currently in theatre listening in between. If you could assist me with that. Thank you.
Thank you so much. Now we are moving to the next speaker, Professor Oleg Sana, Chief of the Neurosurgery Center, Clinical Hospital, Feofania. Hopefully I pronounced well. And he's the president of Ukrainian Association of Neurosurgeons and associate professor of Department of Neurosurgery, Shupik National Healthcare University. He's going to talk about insular glioma. Professor, it's all yours. Professor, we can't hear you. Anyone can hear?
Yes, okay. Can you hear me?
Yes, we can hear you now.
Can you hear me? So
there you are.
Thank you very much for this opportunity to present this talk. I will logically go on the topic started by Professor Yamamoto, then proceeded by Professor Han. Now we are moved to the insular glioma. It's a very specific tumors of the very specific location. I will start from the functional role of the insula in the function of our brain. Actually, it's not clear definitely, but it has a very tight relation with the motor, with the visceral, with the vegetative centers, and also it's a very big, very strong epileptogenic zone, and its main presentation are the epileptic seizures. I will remind you the anatomy. So the insula is covered by the frontal and temporal lobe and is located in the depth of sylvian fissure. And if we will go deeper, we will find the putamen subcortical nucleus and the internal capsule, which is very important for our surgery. This is a first published series by Professor Yassergil. Actually, he was the first who separated this kind of tumor, and as you can see, he presented not so many cases during all of his practice. So these tumors are quite rare pathology. If we speak about the clear insular gliomas. The classification proposed by Professor Yassergil seems quite complex. He separated the 7 types with the subtypes groups. I have not time to explain this this classification. The principle of this classification is the selection of the tumor situated centrally and the tumor extended to the different surrounding areas. There was another classification was proposed by Bergen and Sinai. They only divided the insula to the 4 areas until 4 areas, and connected it with the possibility of resection, surgical approach, and results of surgery. What is very important for surgery of insular glioma is angio architecture around this area. I want to remind you that the internal capsule gets blood supply from the long perforating arteries or lenticular striate arteries, which arise usually from M1 segment, maybe from the beginning of the M2 segment, and they provide the blood supply of the medial-basal structures of the brain. Insula by itself gets its blood supply from the short perforators, which rise from M2 and partially M3 segment of arteries. If we sacrifice all these small perforators, we never will damage the blood supply of the medial-basal structures, because insula has its absolutely separate the blood supply from the M2 and M3. The other things, there is a transit, the middle cerebral artery has a transit arteries which go to the frontal and temporal lobe, which cannot be sacrificed during surgery and must be preserved. It's a for me, it's a key point for the resection of this tumor, is the knowing of angiovasculature. As I told you, the insula is covered by frontal and temporal lobe, and logically there are 2 main routes for this tumor. We can open Sylvian fissure, dissect it, the so-called vascular type, Yassergil type, and then separate and work in between the vessels and remove the whole the tumor, go deeper and deeper. Another type of surgery, it's so-called transopercular way. When we go through the white matter, we always have a arachnoid and pile barrier, so which is covers of vessels of the Sylvian fissure. Controlling of this surface let us not to enter to the Sylvian fissure, not put the blood into the Sylvian fissure, and we can much better control the vessels of the Sylvian fissure. In practice, we use both of these approaches and often combine them if tumor extends to some of frontal or temporal opercular areas. This observing article about modern surgical treatment. You can see the cohorts of patients are not so big. The biggest may be presented by Yasser Gil and Sinai. And according to the approach, the surgeons used both trans-sylvian and trans-opercular approach, maybe with exclusion of Professor Yasser Gil and Vanaklacha. But I think that practically it's much better to use both. Another neurosurgeon, famous, prominent neurosurgeons of nowadays, Professor Dufour, he used mainly transopercular approach, and I think it's wise, and he really protect this way. According to clinical presentation of those tumors, usually they have a minimal symptoms. Their main presentation is epileptic seizures, and when they reach the big size, they can manifest with intracranial hypertension. The diagnosis, the golden standard of diagnosis is MRI with different programs, with different analysis, and so on and so on. But the MRI. Surgery of these tumors is quite complex and requires, first of all, the neuromonitoring. It's the first tool we must have in the OR. Neuronavigation, of course, we need it. Intraoperative ultrasound. If we can use MRI, of course, it's very good, but not so many neurosurgeons nowadays can use it because it's too expensive. Not all the clinical can let themselves to have. And what is very important is experience of neurosurgeon with the surgery of this tumor. Our cohort of patients was not so big. It's 19%. Since 2021, I have maybe some more cases, but I didn't include them to this presentation. The main presentation was the seizures, some hemisymptomatic aphasia, and headache. In our series, the tumors were presented mainly by type 3B, and type 5B. What it means? The tumor extended from the insula to the temporal, to the frontal, and both to the temporal and frontal lobe. We have only 2 isolated cases of clear insular glioma, for which we used the trans-sylvian approach. Let me skip this separation of tumor extension according to the Berger-Sinai classification. When we planned the surgery, of course, we considered the tumor location and extension. And the main symptom of those tumors was the seizures. We thought about so-called disconnective surgery to separate the epileptogenic zone from the surrounding structures and to stop this epileptogenic activity. So that is why I preferred in majority of cases to use the transopercular approach, which let me to preserve the vessel of the sylvian fissure, to have much less blood in sylvian fissure to avoid the possible vasospasm after surgery. And actually, believe me, it's much easier to have orientation in the wound when you go transopercular. Many decisions must be done during the surgery, so you can meet some specific anatomy. You can always must follow the vessels, and what is very important, you must always wait for the lenticular striate arteries. For me, when I see them in the wound, I stop. in spite of data of ultrasound, in spite of neuromonitoring. That's all, because damaging of this sacrificing of this Arctic soil may lead to dramatic results. In our series, I more often use transopercular and transopercular with a combination with the Transilvian approach. A standard patient position, wide craniotomy, intraoperative monitoring. Let me skip because of lack of time. This is 3B type with the extension of the tumor a bit to the frontal lobe. Tumor was removed completely with a good functional result with no neurological deficit. Another type 3B with extension to the frontal lobe with a complete resection of the tumor with very good functional result. This is a quite complex tumor which extended to the frontal and temporal lobe and with a patient with seizures and no more signs with no deficit before surgery. I will present you the surgery. Sorry. In this, I use it both frontal and temporal opercular. We just we got some response to the movement. Then I resect the part of frontal lobe, find the tumor, go on with resection. I do not like the rubber suction. It's not convenient absolutely for me. I like very much the Fukushima type. That is why I use this clamp to connect. This is temporal lobe. So I finished with the frontal part. Now I go through the temporal lobe. Again, I do not, as you can see, I do not open the Sylvian fissure. All the vessels are covered with the arachnoid membrane. This is a medial arachnoid. This is a border of resection. Subpile resection is this dissection is very important for this surgery because it always let you to be not to penetrate. If you do not penetrate the arachnoid, you would never damage the important anatomical structures. This is Sylvian, you can see, I walk around the Sylvian, then go deeper to the insular. And in the depth of the wound, you can see the long lenticular striate arteries. This is a border. I stop at this. I always stop level. Even if I see the tumor there, I also stop there. This is post-op control with no deficit, absolutely no deficit. This patient came to control after a couple of years, no tumor growth. He works, sorry. Another case, left side, also with no functional deficit, without no speech disorders, with good result. According to the pathology, in our series, we have the half of the tumors were grade 3 glioma, and equally G2 and G4 tumors were presented. We had some complications, and all of them were in patient with not benign tumor with the G4 tumors. Unfortunately, these patients are very difficult this patient to have a good functional result. Follow up. One patient with the G3 was reoperated in 3.5 year due to progression of the tumor after subtotal resection. Median survival of G4 tumors was 2.5 years, which is not so bad result. According to the predictors of our surgery. The presence of, we always must avoid the neurological deficit in patient with this tumor before and after surgery. So it was very good presented in many publications that a preoperative deficit and post-operative deficit are the most unfavorable factors of bad prognosis in this surgery. In conclusion, we want to say the insular gliomas, the very rare specific group of brain intrinsic tumors which could be successfully managed surgery, await anesthesia and intraoperative neuromonitoring are obligatory for this surgery. Transsilver and transopercular accesses to these gliomas and their combinations should be used for their removal. Microsurgical arachnoid dissection and some pile tumor resection are the main surgical maneuvers for this surgery. Tumor histopathology is the most authentic factor for prediction of and post-op prognosis. And my message is that if you see insular glioma in young patient, which already manifested with at least one epileptic seizure, I think it's essential to consider the surgery and to start to discuss this surgery with the patient. So early surgery, surgery of benign tumors, will be much more effective than late surgery with the transformed, not benign tumors of this localization. And thank you very much for your attention.
Thank you so much, Professor. Congratulations. Nice talk. Very comprehensive. Dr. Landry Conan is with us. Dr. Landry Conan is not there. Okay. Professor Yamamoto, any comment? Yes. Professor Sarah also. Carry on.
Yeah. No, I just wanted to ask a question about these insular gliomas. Sometimes, you know, they're really big. They involve the frontotemporal area and the insula. And, you know, I had a good run with them. And then I had was doing one awake in a young man, a radical resection. And he was fine. He went to recovery and then he had a bleed on the opposite side. And I think there's a change, you know, with taking big tumors out, you get a change in the transmural pressures of the veins, and you sometimes get distant bleeds. And I have wondered whether, you know, when they're so big, whether you're better off doing them in 2 stages or whether you just, have you experienced this? How do you minimize that sort of thing happening?
Thank you for the questions. I haven't understood clearly what problem had the patient.
He had a radical resection of a big insular temporal frontal. Had a bleed on the opposite side in recovery.
I see the bleed. Okay. I see. I don't know. I don't know how to predict it. Sometimes, if you do neurosurgery, you cannot predict the complication you have after your surgery. So it's quite difficult to explain it. So maybe it's a kind of unpredictable complications like this.
Do you think, I wondered whether I should have done it in 2 stages instead of doing a big operation to start with. What do you think about that?
2-stage?
2-stage operation?
No, for this localization, no. I'd recommend to be more radical and to do awakened anesthesia and to be more radical at the single procedure.
Thank you so much, Professor Sarah. Professor Alexandra, I saw one picture where you mentioned, when you showed, you did the transopercular approach, and there was a huge cavity in the brain, in the place where the tumor was. In your experience, long-term follow-up, does the brain expand or that cavity will remain like that, like giving passive hydrocephalus?
Okay, thank you. No, in this localization, the brain doesn't expand so much after surgery. I can explain it by the very slow growing of this tumor, and they like prepare the room for them, and there is no brain tissue to fill this room after tumor removal. And if you could see the late control MRI controls, all the cavities are still exist. They are not filled. There is only CSF inside of this cavities.
Thank you, Professor. Any question from the audience?
I think maybe Dr. Yashin.
Just question.
Yes, Yasin.
Thank you for the presentation, Professor. About simulation, Professor, did you use the section simulation system, or just in every step you stimulate in resection?
Okay, thank you. First of all, on the dominant hemisphere, we always use awake anesthesia. It's the first. We talk with the patient, we control the area. Then we use the cortical stimulation, bipolar stimulation for when we need to find the motor area, when we need to find this Broca center. We use this. And then after this, when I have the cortex, we finish with cortex, we go to the monopolar subcortical stimulation, which I perform permanently during surgery. As you see, the cable fixed on the my suction, and I have it all during all the surgery, even if I do not need it in this area, for example, the temporal area. Anyway, I have it. I stimulate on the depths about 2 centimeters. I start from 2 centimeters. Thank you for the question, because I want to explain that. Of course, I stop when I see the lenticular striate arteries, but electrophysiologically, I stop in 5 millimeters to the internal capsule. Depth 5 milliamperes, so 5 millimeters. It's almost equal, but I always have the stimulation at 2 centimeters. When I get the signal from 2 centimeters of the internal capsule, I decrease the level to 10, then to 5, and only when I obtain the signal on the 5 millimeters, I stop. That's the border. I never move, in spite of the situation in the wound. Either I remove a tumor or I don't remove the tumor.
Thank you, Professor.
Thank you, Professor. Any other questions before we move to the next speaker? Okay, handing it over to our host, Professor Abidasha, to introduce the next speaker. Thank you so much, Professor Alexander.
Yes, thank you, Professor Kabulo. I think the next speaker is Professor S.C. Ohel Balun. He's from Africa, and he's going to be talking on evolving neurosurgery in Africa, co-Wadis. Are you there, Professor?
I don't think so.
He's not there?
Yeah, I think so.
I don't think so.
Okay, then the next person is Professor Ravi Verma, and he doesn't need any introduction, and he's very good functional and a neurosurgeon from our country. And I hand over the stage to him, Professor Verma.
Thank you. Thank you so much. I hope I'm audible.
Yes, sir.
Yes.
We cannot see your screen yet, sir.
Yeah, I'm just sharing it in a minute.
Yes, sir.
Is it seen?
Not yet.
Not yet. Not yet.
Yeah, I think it's seen now. Can you hear? Is it seen now?
Yes, Professor,
Yes,
we can
yes,
see.
yes.
So thank you so much, Dr. Yoko Kato and Professor Yoko Kato and Professor Abhidesha for inviting me for this talk. I'm very happy here to talk to the African nations because I love Africa. I've been visiting Africa quite often. I've been in Ethiopia. I've been to Kenya and other places, and it's a very, very beautiful country. So I'm going to talk on a very simple surgery, a very beautiful surgery. It is a microvascular decompression for trigeminal neuralgia. Trigeminal neuralgia is a very painful event, and we all know that the patient comes with severe pain. I have had patients coming with loss of weight because they can't eat, they can't brush their teeth, they've come with caries. I've seen patients who come with multiple teeth removed because of trigeminal neuralgia, because of lack of knowledge of awareness among our dental community too. And we have seen trigeminal neuralgia with hemifacial spasm, trick dolorosa, and the surgery is a very simple surgery. All you require is a microscope and micro instruments. You don't need navigation. You don't need neuromonitoring. In fact, if you have neuromonitoring, it's an added help because you can stimulate and see the nerves. But you can do a very beautiful trigeminal neuralgia surgery without all these high-end equipment, and microscope is all that you require with fewer micro instruments. And we always place a Teflon patch between the conflicting nerve and vessel. So it's a very safe procedure if done safely and if adequate precautions are taken. But there are complex microvascular decompressions too, which is the focus of my talk today. I would show a little bit of what we do in a normal case, and then we would go in for more complicated cases. So the indications are typical drug-resistant trigeminal neuralgia or hemifacial tic dolorosa. Drug response, but then the side effects are too much, and they keep increasing drug as the disease progresses, as the conflict makes the damages the nerve more and more. Even the drugs start becoming less effective, and increased dose of drugs. I've seen patients who come in very drowsy because of high amount of anti-trigeminal medications like Tegretol, carbamazepine, or any of those neuromodulating medication. I always operate only if I'm very convinced that the MRI shows a neurovascular conflict. Our oldest patient is around 80 years. I've not operated anyone above 80, but that is not, it's a relative contraindication. If there's a very fit person who's beyond 85 and 90 and they are suffering from pain, we are justified in offering surgery because the pain has to be relieved. So I took a small series of from 2016 to the present, and we had about 125 cases. All of them underwent a CIS 3D and a TOF imaging before surgery, so that we have confirmatory diagnosis for a conflict. And the neuroconflict in these they were seen with the superior cerebral artery, the anterior inferior cerebral artery, and some veins. In some situations, we had both veins and arteries. We had 4 dolichoectatic basilar arteries, which are the cause for trigeminal neuralgia and hemifacial spasm. We have had tumors, which primarily present with trigeminal neuralgia, and I have 4 recurrent cases. So I'll show a recurrent case too, and these have been followed up for a minimum for a year, and then we've been following them up on a regular basis. So in our experience, the arterial the conflicts were much higher than the venous conflicts. The outcome of venous conflicts were not as good as the arterial conflicts. The medications were usually carbamazepine, and then some of them had other neuromodulating medication. Recurrence was seen and in some of them, and resurgery was done in 2 patients, and we had 2 of them who had lost for follow-up. The 10 recurrent patients we had, we treated them with percutaneous injections and rhizotomies percutaneously using RF generation, and that gave them good relief, but a bad sense of numbness in the referred area. Complications, we didn't have any mortality, infection, or hemorrhage, thankfully. Pseudomeningocele or CSF leak. We had 1 patient who had tinnitus and 1 patient who had persistent facial numbness, and one of them with a hemifacial spasm and trigeminal neuralgia together had persistent facial palsy. But they also improved in due course with exercises regularly. So this is just to show what an MRI can see. You can see here very clearly this is the nerve and this is the vessel in conflict. So good imaging is very helpful for us to confirm whether we need to go in and remove separate the vessel and the nerve. So in this MRI, this is what was the intraoperative picture. You can see the nerve being compressed by the offending superior cerebellar artery. And this is what we do. We separate them and then put Teflon right there. And this is what is done in a normal, straightforward surgery. So the crux and the essence of surgery is adequate arachnoid dissection around the nerve. Because if your arachnoid dissection is very good, many of the vessels by themselves move out and do not come back. So you can prevent a lot of recurrences. So one has to find out the nerve being the vessel that is offending the nerve and clear the compression 360 degrees. So one has to look all around, because sometimes you feel that one point is the compression, but then you might find another compression, the posterior part. So one has to completely inspect the nerve through and through, and then only deal with the offending artery. Because the chance of recurrence is high if you do one point and you see another point at the posterior part as another offending vessel. So one has to see 360 degrees. One has to feel the see the nerve completely free from any offending vessel, and then you have done adequate. So I would go into the more complex ones now. So this was a patient with an acoustic neuronoma who would come with left side hearing loss and episodic facial pain since 6 months. And that was the MRI. You can see the MRI here. There's a huge tumor, a small moderate sized acoustic nerve. And you can see at that point, you can see the 5th nerve also right here. If you see, that's the 5th nerve there, and that's been compressed by the acoustic. So this is surgery done regularly, the retromastoid, what we plan for your acoustic tumors. And due to the internal decompression of the tumor throughout monitoring the facial nerve. Once we remove the tumor completely, you can see here, this is part of the tumor with the facial nerve attached. There you can see the 5th nerve very clearly with the offending artery just below the axilla of the nerve. So one has to, after tumor decompression, do a microvascular decompression of the 5th nerve. Otherwise, you will remove the tumor, but patient will continue to have the hemifacial pain, which is very, very bothersome compared to the loss of hearing. So therefore, one has to check the nerve, see the nerve, dissect the nerve away, dissect the vessel away, and then use Teflon wool to keep it separate. And the entry zone has to be cleared of the nerve, of the vessel completely from touching the nerve. This is a case of a meningioma. You can see here the MRI, which shows very small meningioma right there. And that is the meningioma. This is the nerve that is going there. And you can see a blood vessel right above that. So this is the offending vessel with the nerve sandwiched between the tumor, the vessel sandwiched between the tumor and compressing the nerve. So this surgery also, we had decompressed the tumor as usual, what we would do for any meningioma, start from the base, devascularize the base completely, and then use QSA to decompress the tumor, even though if it is small, because our area is very little. If we need to get access there, we need to decompress the tumor. decompress the tumor once it's avascular, then dissect the tumor away from the arachnoid in and around, because there is always an arachnoid plane that is there which separates the nerve from the tumor. And once we remove the tumor, we go in and see the fifth nerve. This is a flattened fifth nerve. You can see it extends all the way in your operating field. And right below that nerve is the offending artery. So one has to take care of the artery, because once the tumor is removed, the trigeminal plane can continue, and it's very, very important to inspect the nerve through and through on both sides of the nerve, so that you can see the Teflon right there beyond the nerve on both the superior and the inferior aspect of the trigeminal nerve. So this is the post-op scan. You can see the tumor out. This is the nerve which is straightened out. That's a Teflon there, and there's a blood vessel which is away from Teflon, and here. This is a little more complex, because a dolichoectatic basilar can be really difficult to mobilize and to move. So the general principles of what we use for microvascular may be a little difficult to mobilize the blood vessel away. I have some 2-3 surgeries which I'll show you. So this is a patient who is a 70-year-old who would come with a right-sided pain. You can see this is the huge dolichoectatic artery, and that is the nerve that is going in through here. You can see the vessel right across here, right there. And this is the basilar down below. This is the 4th, 7th, 8th complex there. And this is the 5th nerve here, the normal 5th nerve on this side, and the compressed 5th nerve on that side. So this is again, the position is the same. The surgery is very similar. But here you can see this huge vessel is the dolichoectatic vessel. And here you can see is the facial nerve right here. So as I always insist, it's arachnoid dissection, safe arachnoid dissection. Spend some time in working out the arachnoid, move the arachnoid as much as possible. So when you mobilize the vessel, you do not have anything pulling a blood vessel. So I have now put gently a retractor on the ectatic basilar artery, and I'm working on the arachnoid. You can see the superior cerebral artery right there, compressed on the nerve very clearly. So again, arachnoid dissection, arachnoid dissection, arachnoid dissection. That is what is most important in complex MVDs. We need to just work on the arachnoid, mobilize the vessels. You can see here how we are mobilizing the vessel, and there's still some arachnoid adherent. We will work out on that arachnoid, try to remove that arachnoid, and then mobilize the vessel. You can see that groove that is created by this vessel that is right across the trigeminal nerve, causing severe trigeminal neuralgia. Now, once we mobilize this, you would see, once I remove this retractor, you would see that the basilar gets back to the point. You can see how it gets back. So we need to work on that. So here we need to do a couple of things that would help. One is I decided to put a Teflon sheet first, not a wool sheet, just across, so that it covers the nerve completely on either side. Once we isolate the nerve from both with the Teflon sheet, then I would put Teflon wool to keep the vessel away. And this Teflon wool, this Teflon wool is placed between the artery here. You can see that. We keep wool there. And once that is kept, once you release the basilar, it stays away. So that is how you keep wool. So there's wool there. There is a Teflon sheet there. And I would even put a wool here to keep this totally separated, the artery totally separated, and the nerve is well insulated from the pulsation of both the vessels. So this is another patient who had come with tic dolorosa. He had severe hemifacial spasm, plus he had recurrent pain, facial pain. So this is what he had, a spasm. More than the spasm, what he was worried about was his facial pain that he had, shooting pain. This is the MRI, which shows there is the ectatic basilar going all the way down there, compressing the 7th nerve, 8th nerve complex, and going all the way up towards the So that's the seventh nerve, eighth nerve complex. And you can see it goes all the way up and compresses the fifth nerve, which is right there. So that is what the MRI showed. Surgery-wise, it was a difficult situation here, because if you look what happens here is you have the lower cranial nerves here, you have this huge vessel there, and you have the seventh nerve here and the fifth nerve here. So there's compression all through. And so we decided that if we have to get, each time we try to mobilize this vessel, we couldn't, it used to come back, rebound. So then we decided that we would go down to the lower cranial nerves and start mobilizing the vessel from there. So we put Teflon right there in between. These are the lower cranial nerves. So we put Teflon sheets right there, pushed the vessel down. So as we did that pushing, we saw that this vessel was moving away from the fifth and the seventh, eighth complex. So once that was over, we put a Teflon wool there so that it would stop the thing there. And then again here, the fifth nerve was separated, and then Teflon wool placed near the fifth nerve. So that this is the seventh, eighth complex and fifth nerve right there. And we had completely mobilized the basilar, tortuous basilar artery down. He had good relief. His hemifacial spasm had totally gone. You can see that. And mild facial was still persistent. I'm sure that will improve in due course with exercise. And he was totally pain-free. His facial weakness was same as the pre-op facial weakness. This is another patient, again, came with 12 years of hemifacial spasm with severe hemifacial pain. The hemifacial pain was so acute, it started only a week before. He was not worried about the hemifacial spasm as much as he was worried about the pain. What brought him to the hospital was the severe pain. This is what he was when he came to the hospital. He had a facial weakness. You can see that facial weakness there with continuous spasm of the angle of the mouth. This he said he would live with. But what really bothered him was the pain that shot across right there. And he said that is what has brought him to the hospital. He was not worried about the facial weakness. He was not worried as much as the twitch, but he was definitely upset with the pain. So this was this MRI, again, showing the both vertebrals becoming the basilar and being ectatic all through here. This is the lower cranial nerves. As it comes up, this is you can see how the seventh, eighth complex is pushed to the one side here. We just come to that. And that's the fifth nerve, which is right up there. And the surgery was similar, very difficult to mobilize. We were not able to mobilize, but here we had the ICA coming right across the seventh nerve. So we separated the seventh nerve, put a Teflon there so that the ICA was taken care of. The hemifacial spasm was first taken care of. Then we mobilized. You can see how the artery had compressed the nerve. We were not very convinced that we would be able to move it or give him a relief, but we said we would anyway leave a Teflon insinuated between the nerve and the artery. We mobilized the artery to a certain extent with anechoic dissection and then placed this Teflon wool right there. So you can see this Teflon wool there, the vessel there, and you can see the fifth nerve there. So we were not very convinced. We were wondering whether he would get a benefit from this because compression still is there. And I'm not sure what exactly the Teflon is going to do there, but definitely we thought if we would do this and probably go for an injection or RF lesioning of the nerve. But fortunately for us and for the patient, he's pain-free. His facial weakness remains the same. Twitch does not exist anymore. And his pain disappeared. And this was a video sent by him from his house saying that he is absolutely pain-free and he was glad that he went ahead with the surgery. Another tough microvascular decompression is recurrent microvascular decompression. So he was operated, he had left-sided pain. He was operated for the same in 2013. He came to us this year with recurrent pain. That is apparently after 6 years, recurrence of pain on and off. We did the MRI and you can see the Teflon patch there. And between this to above that, there is a nerve and there's a vessel. So probably we needed to go again. We went again for the surgery. Resurgery is a little difficult because there's a lot of adhesions. You can see how the nerve is adherent. This is the Teflon which is kept there. And you can see here there is a nerve, a vessel that is which is outside the Teflon and is at the root entry zone, causing the pain that he had. So we had to mobilize the whole thing. The nerve was mobilized, you can see here. And once the nerve was mobilized, you saw this is the loop that is going right across the root entry zone. So we had to mobilize this nerve and then put in a Teflon there to separate it. And you can see the nerve below, and this is the offending artery, which is insinuated between that and the nerve. And he had pain relief after that. So in conclusion, I think technological advances are helpful, but what is most important is safe surgical approach, intraoperative monitoring if you have it, well and good. The imaging is very important, this 3D with TOF MRA, which gives us, you can differentiate between an artery and a vein too. And then intraoperative endoscopy, especially if you want to see behind the nerve, which you can't see, you can use an endoscope. We've done it at some points. And all these things has improved the efficacy of MVD. We have had about 80 to 100% success rate in these things. Sensory neural hearing loss is common complication. We have had it in one patient, and which improved in due course. Failure again is due to inadequate proximal dissection, and the root exit zone needs to be taken care of. Thank you.
Thank you so much, Professor Ravi. This is a wonderful presentation. Okay, do you have complications about that Teflon?
So we have had no complications with Teflon at all. I've been operating microvascular, doing MVDs for the last 25 years, 25 to 30 years. All the while we've been using Teflon. I have done 2-3 resurgeries where people had put in muscle or cotton, and a lot of additions happen. We have reoperated patients with Teflon. We have seen that there is very little addition. And so the tissue reaction is very good. We have not had any problem with Teflon to date.
Thank you so much, Professor. Professor Kalangu, comment?
Thank you very much for this excellent presentation. Beautiful. Okay. So my question is this. Do you always have the neuroradiological proof that there is a compression before you operate?
Yes. So we always have a proof, and we want to see a vessel in confluent. It could be a vein, it could be an artery, but we always do imaging, because I have not operated a patient without imaging proof of microvascular contract.
What about a patient with symptoms suggesting?
Yeah, so then we rule out
but
other.
You can't prove it neuroradiologically. What do you do?
So such patients, I think we offer them RF. We go through foramen ovale and give an injection or an RF ablation of the nerve or a balloon compression. All of this, prevents the anesthesia and reduces the pain. I have about 5 to 10% of my patients I have done this, and we've got mixed results. There are a few patients who require repeated sittings, maybe once in 6 months, once in 8 months. We have had patients who had just one injection and they're fine, they're quite okay without trigeminal neuralgia. But I'm very wary to operate if I don't find a vessel on MRI. The imaging has become so good that we are able to even if I have a little doubt, I go in. But if I have no doubt and there's no vessel around, I don't go.
Thank you very much.
Welcome.
Congratulations again.
Thank you.
Thank you.
Thank you so much, Professor Ravi. That is one of the area I enjoyed during my fellowship. I even wrote a paper with Professor Kato and Professor Komatsu about microvascular decompression. So another question is, do you sacrifice the superior petrosal vein in case it is obstructing you to reach the nerve?
Many a times I have been tempted to do that, but I've never done it. I try to find a corridor where I can go through, keeping the vein safe. I have one issue when we tried to do that and there was a bleed. So I took nearly an hour to achieve hemostasis. And in fact, I had left a little cotton there to prevent any more bleeding and then continued with the MVD. But I prefer not to remove the vein because one complication I have seen in my training period was when the vein was coagulated, pain went, but there was a huge, venous hemorrhage into the cerebellum, and we lost that patient. So I'm very scared to remove any vein. I would work on the arachnoid. I would dissect the arachnoid, find a new corridor, and then do the needful.
Of course, even Professor Komatsu, Professor Kato, they don't sacrifice the superior petrosal vein. They keep it. And maybe the last question before Dr. Sam asks the question, do you also try to do transposition? Because Professor Komatsu does it endoscopically and then mostly transposition instead of Teflon. Of course, he uses also Teflon, but most of the time he does transposition.
Yeah, so I also believe totally in transposition because that is the best. But then for me to sleep well in the night, I put a little Teflon because I don't want it to come back. So, but yeah, transposition is the best. Work on the arachnoid, separate it, see that it's all separate. But to sleep well, I leave a little Teflon.
Thank you, Professor. Professor Samjo.
Hi, thanks, Kabulo. Yes. Thanks, Prof. Ravi, for excellent lecture. I would just like to ask whether you have had any experience in which if you overdrain the CSF during your microvascular decompression, you get transient third nerve, sixth nerve palsies, and if you have had that, how do you avoid them from happening?
So what I do is I do not open any CSF space unnecessarily. I just go, into superior angle. I make a small craniotomy in the superior angle, go down and open only the cistern of interest. As you said correctly, if you suddenly release CSF from here and there, or if you have a tight cerebellum, then you want to release, you can get these nerve affected, but they improve in due course. But what I think is the important part is just work on the arachnoid around the fifth nerve. And then if you still cannot get, then go another cistern, open the cistern around the seventh, eighth complex, open the cistern in the superior part of the fifth nerve. So if you would gradually open these cisterns, then you don't have sudden gush of CSF coming out. And also you get a better corridor to find out which is the offending vessel.
Right, thank you.
Thank you. Okay, maybe the last question, Dr. Yassin.
Thank you. Yes, thank you, Professor.
Yes, Professor.
Yes,
maybe after Yashin.
Okay.
Thank you. Thank you for your wonderful presentation, Professor. Professor, my question about pure endoscopy. What do you think about pure endoscopy in trigeminal neuralgia?
I mean, I'm totally for it. I don't have any objections. But the amount of craniectomy that we do, or the craniotomy that we do, is a little bigger than a burr hole, which is required in endoscopy. And the amount of retraction I do on the, even microscopically, the amount of retraction that you require is also very little. So I think it's possible to do with endoscope, and I've seen people doing it with endoscope. But in a complex case like a dolichoectatic vessels, which I just showed you, I don't think endoscopic alone would be very helpful because you need to do much more bimanually than putting an endoscope and then working on that. Also, the heat of the endoscope, I'm also a little wary about it. You can, as you're working on one cistern, the heat can affect your fifth nerve, seventh, eighth complex. So I'm not so much in favor of that. But I don't have the experience to use an endoscope. I feel just doing a small craniectomy is good enough. So I just have not tried an endoscopic method. I don't find an advantage.
Thank you, Professor. Kato Sensei.
Hi, Domo. Thank you very much for that wonderful talk. Maybe I think, of course, the pure endoscopic surgery is sometimes better than the microscope, I think, because of the very high illumination and magnification and very precise image. So, but sometimes you mentioned about the very difficult case, such as the dolichoectatic or very large the vessels is offending vessels. But my question is, because I had one case, the once the CSF leak, suddenly the MEP has disappeared. So then they never come back. So I think maybe some stretch of the nerve or sometimes maybe some microcirculation has disturbance. How do you think about it?
Yeah, so we've had, luckily we also keep, all our patients have neuromonitoring while we do it. And we have luckily not faced this. We have faced this with neuromonitoring when we do spine surgery and other things, where we suddenly get a blackout and then the patient outcome is good, but we get a blackout while we are operating. But with microvascular decompression, I've never had a situation where we have not got an MEP or we have not got a stimulation parameter going right. So maybe I've not had that experiences yet.
So I want to ask maybe Bosniak, one comment for you.
Thank you, Professor Kato. Professor Varma, thank you very much for great presentation, great cases, but I wanted to ask you about the pre-op MRI. Okay, but my question is, when you actually do not find the conflict at the surgery, what would you do? That's the first my question. And another question, it's a practical question. When you have a patient, a young lady with typical trigeminal neuralgia, she's potentially is planning to get pregnant in the future. Would you start with Tegretol, or would you recommend the procedure at once to lady in this situation?
Yeah, so the first question, I think if I go in, I have a doubt on the MRI and I go in and I find that there's a vessel, but it's not conflicting. There's nothing there. I 360-degree look at the nerve. I look at the entry zone, exit zone. I don't find any vessel. The old saying that if you massage the nerve a little, you break the vicious cycle, because pain is such a wonderful thing. Sometimes if you break the vicious cycle, it does not come back. So I just massage the nerve and then come out, and I've seen many of them cured by that. And then very, very few of them come back saying, and then I go for the RF. But otherwise, I just massage nicely, just play around with the nerve a little, and then just leave it. That's one. The second question. Second question is, could you just tell me the second question?
Second question, young lady with a plan to get pregnant. Yes.
So yeah, for them, I would suggest to go ahead with MVD, and I would stop the medications.
Yes, thank you. Thank you.
Thank you.
Thank you so much, Professor. There's a question Q&A. The question is coming from Dr. Sukirti Chushoha. Sometimes patient is symptomatic without the radiological evidence. Should we consider surgery in those cases?
So I personally do not consider surgery if I don't see anything in the vicinity. Even if there is a doubt, there is a vessel, then I would go in. But if I'm very sure with the latest advances in imaging, and you're very sure that there is nothing compressing, then I wouldn't go in for an MVD per se. But I would look at other options. That's personal, my personal.
Then, Professor, will you not consider it as idiopathic? Then you go and do neurolysis if medical treatment fails.
Yes, probably I would use balloon, compression, or an RF, short RF, so that only the sensory fibers are taken care of. So probably I would do that. Yeah.
Thank you so much, Professor. Thank you. This is a very nice talk, but we have other presentation. We might spend the whole day here. So I'm now, since my chair is busy in theater, I'll ask Dr. May to introduce the next speaker. Dr. May?
Yes, I'm here.
Yes. Good. She's the secretary of Young African Neurosurgeon Forum. So you can introduce Prof. Sarah.
All right. Thank you very much, Dr. Kabulu. Our next speaker is
I think she has a problem with internet connection. Our next speaker is Prof. Sarah Olson, Associate Professor and Visiting Consultant Neurosurgeon, Department of Neurosurgery, Princess Alexandra Hospital, Brisbane, Australia. So Professor is going to talk about the death of ablative surgery. Professor, it's all yours.
Thank you very much. Thank you for the invitation. I'm really enjoying meeting you and listening. I haven't been to Africa yet. I'm coming for the WFNS, so very much hoping to meet you in person. I'm from New Zealand originally, but I work now in Brisbane and interested in functional neurosurgery. I work in Gamma Knife. We've just introduced laser. I do a lot of pituitaries and brain tumors as well. So this talk is very controversial and somewhat lighthearted. I was assigned this side of a debate against the great Aviva Abosh, and I really wanted to win, but I actually do really believe in everything that I'm about to say about the death of ablative surgery for movement disorders. So I was initially trained in radiofrequency lesioning. It was DBS was available, but only in the private sector in Australia. We have two sectors: the public sector, which is everyone who has a Medicare card is eligible. The idea is equal care for equal need. But for things that such expensive like DBS, it was a long time before we could get that. Maybe 15 years after it was available in the private sector. So I was trained in radiofrequency lesioning initially, and then we campaigned very hard to get some funding for DBS. And we were the first place in the country to get it back in 2006. I also do gamma knife thalamotomies. I haven't done focused ultrasound, but my group I work with about an hour from me, they have a focused ultrasound machine arriving soon. And so we're hoping to be able to offer everything to our patients soon. So I haven't done a radiofrequency lesioning for some years now, many years probably. The last was a girl who needed repeated MRIs, so I didn't want to put DBS into her, but I exclusively do DBS now. I'm going to talk about that and how that happened, and we'll hopefully raise some questions about it. So this is where we are in Brisbane. So the death of ablative surgery, is it progress or is it a cautionary tale? I'll let you decide about that. So really, when it came out, it was pushed really hard. It was marketed very hard. Basically, if you weren't doing it, you were old-fashioned and you should be put out to pasture. And young neurosurgeons were dragged, like me, were dragged along for the ride. And of course, if another hospital's got DBS, you really want DBS. I think this is ubiquitous, this keeping up with the Joneses. In Australia, that's usually about, boats or how many burners you've got on your barbecue. But also, if another team has something, you really want that. And even if you don't want to drink the Kool-Aid, you're going to have to, because there's no money in radiofrequency lesioning. And if you want money for your education and your conferences and your fellowships, you're going to have to drink the Kool-Aid and do the DBS. But what's the evidence? There have been no published randomized control trials demonstrating the superiority of DBS over any types of lesioning. It's much more expensive than even focused ultrasound, the most expensive of the lesioning procedures. And there are studies suggesting that radiofrequency lesioning is more effective than DBS. And, this is a good 20 years almost later after it was introduced. A group got together who I think were also a little bit concerned about its rapid takeoff. And they agreed that, radiofrequency for pallidotomy should remain in the surgical armamentarium. Lesioning didn't carry any more surgical complications than DBS, and in fact, unilateral pallidotomy was better than DBS for dyskinesias. So, of course, the functional neurosurgery community listened. No, they didn't. They threw the baby out with the bathwater, and now pretty much it's very, very rare for people to do radiofrequency lesioning. And DBS there's no doubt it's been life-changing therapy for hundreds of thousands of patients, but there are problems that have become apparent. Firstly, is the cost. It's really very expensive, especially with your outpatient visits, which I'll talk about next. So when you did a good lesion, you never saw the patient again unless they wanted the other side done. So it was just one post-operative visit, a bit like a good clip in aneurysm surgery, I suspect. And now we've sort of settled with seeing them up regularly with their MRAs, with their coils. But now, especially with these multi-directional leads, it's an extensive interaction for DBS and a real drain on resources. And of course, I think people get a bit sloppy with their surgery with DBS. With lesioning, you really had to get it right. It was painfully obvious if you didn't. But now you can rely on multi-directional electrodes to combat poor targeting. So this was the original patient that I was really after DBS for. We had done a radiofrequency lesion on one side and on her right side. And then but for thalamotomy, doing bilateral lesioning was always quite worrying. And so I really wanted to do DBS for her on that side. Well, 20 years later, after a radiofrequency lesion, it's still working. That's working still well on the right side, but this left side fell apart within about 2 years of having the DBS in. So longevity has always been a bit of a question. Bilateral lesions, I think that, that's always been a bit of an issue, especially bilateral thalamotomy. But, focused ultrasound is showing us that we probably can do it. And Jean Regis in Marseille does bilateral thalamotomies, gamma knife thalamotomies. So it's still a bit of a query, that one, I think. And of course, there's hardware complications with DBS that you don't see with radiofrequency lesioning. There aren't any infections, erosions, fractures, migration, or device malfunctions. And getting an MRI in somebody with a DBS, I don't know about in other countries, but here it's really hard. They put up lots of obstacles to doing it, even when we've got them all approved. So, and we know that 80% of people are going to need an MRI in their lifetime. And if you can't get it, then potentially, you can put the person in a life-threatening situation. And of course, patients now, they don't really want to be settled with their doctor forever. They don't want repeat programming or battery replacements. They want a minimally invasive treatment. Now, psychiatric surgery, I find this just a bit ominous. So DBS is marketed as non-destructive, reversible, and somehow it's more legitimate. But it's not been shown to be more effective or safer than ablation. And in fact, radiofrequency is more effective than DBS in a meta-analysis. So pretty much once you've got DBS and you're hooked on it, it's for life and needs life maintenance. Now, why would you do that to someone with OCD? That is stunning to me. And of course, then you're chained to your doctor forever. And I think most people really just want to get on with their life. So is DBS more ethical than ablation? I think there are definitely ethical issues regarding the world population. And I think there are ethical issues where people really don't get appropriate post-operative care. But so particularly on equity, I mean, radiofrequency lesioning had a capacity to be able to treat the entire world population instead of only the 20% of the developed world who can afford DBS-focused ultrasound or gamma knife. And I think it's a real shame that it has died out. Acute failure doesn't happen with lesioning, but acute failure of DBS can be life-threatening in some patients with severe dystonia or psychiatric illness and lead to death. Now, this is a patient of mine. I have consent of his family. So he had DBS for his Parkinson's. He did very well with it, but he underwent a multi-level fusion with a spinal surgeon, and they had the monopolar turned right up for the entire procedure. Now, you have to use plasma blades. You can't use monopolar with DBS, and nobody paid attention to it. No one put it into safe surgical mode. They've got to be treated like a pacemaker. And this is how he woke up. So I think you can see pretty clearly what's happened there. So it's all one big Kafkaesque maze, really, as to what's really going on. And I do think we've been gaslit or convinced against perhaps our best intentions. So which is it? Is it progress? Yes, it probably is, but I think it's also very much a cautionary tale. So lesioning is a noble art, to quote Professor Tyra. I think as the medical profession, it scares me a bit how so many clever people can be convinced something with little evidence behind it. I mean, you just have to watch Painkiller. How many doctors just went on to prescribe these opiates with such little evidence, but push on marketing? And I think patients are best served when they have access to all therapies. Sort of mentioned this honourable man who never caved and always did what he did well and never bowed to pressure. So he's an expert in radiofrequency lesioning. And I think I'd rather drink tea than Kool-Aid. Thank you.
Thank you so much, Professor. Do you want to take directly the second talk?
Sure.
Do
Let's do that.
Or
yeah,
I think.
Yeah, I will do that. Let me see. I've got that here. I'll just drop this one down and I'll get the other one up. I should be able to do this.
So, Dr. Olsen, thank you very much for nice presentation from Australia. Thank you. So, just I want to ask because the time is less invasive, the treatment for the patient and also the doctor. So, what about the skull-based lesion? I think, of course, the size or some limitation for the radiosurgery, but I think in the future, is there any plan how you can attack or how you can treat with such a skull-based lesion tumor?
That will be more with the laser with the next talk, I think. This one?
Oh yes, please.
Yeah. This one, I think. Some people are doing it, but that's still very. Just a few people sort of doing a little bit of work on it, but I'll talk a bit about laser interstitial thermal therapy. So when I was in Marseille, learning how to do gamma knife thalamotomies, Professor Gross was there, and he gave a really interesting talk on laser interstitial thermal therapy. And I thought I've got to keep an eye on this. Is it going to be like the lasers of the past, which really didn't grow too much? I think in the 1980s, there was quite a few lasers around, but it sort of died out in neurosurgery. So I'm going to watch this and see what happens. And what was happening was that it was actually really expanding over the world. There were a lot of hospital centres and a lot more procedures being done with laser interstitial thermal therapy. So lasers have been around a long time, but the initial ones lacked the cooling and insulation to actually be really effective. So the introduction of CO2, sorry, I'm just going to drop this out of the way so I can read myself. The introduction of CO2 and saline probe sheaths allowed for increased use of the laser power. So light energy is converted to thermal energy by the surrounding tissue. Photons emitted by the laser optical fibre are then absorbed by tumour chromophores, resulting in chromophore activation and the release of thermal energy. So basically, light amplification through stimulated emission of radiation, and the thermal damage is time and temperature dependent. But if you're below 43, 44 degrees, you're not going to get any damage to tissue. We're aiming at about 60 degrees. So when we're planning we look at places we do not want anything to get above 43 degrees, and we look at places we want to get above 60 degrees. So now they will tell you can get up to 3 centimeters wide with a single laser probe, but it's really 2 centimeters. I've tried with a patient and I couldn't get any more than 2 centimeters. But what you can do, a long thin lesion like amygdalohippocampectomy is very attractive because you can go into the MRI machine and just pull it out notch by notch. For those who haven't done that before, you get quite acutely seasick going in there. So you do feel quite unwell, but you have to go and just pull it out a little bit each time. So usually 2 weeks after the ablation, the lesion grows and then the edema resolves over 2 to 9 weeks. And it's a very sharp transition zone between dead and viable tissue, a little bit like proton therapy, very sharp. So the indications are glioma, which we'll talk a little bit about, usually those that are deep, that have failed other treatment, metastases that have failed treatment and radionecrosis, epilepsy, pediatrics. There is some suggestion, we haven't done a pediatrics case yet, but that you might be able in the very young patients to delay radiotherapy, which I think all of us would like to see. And cavernoma, some data is coming out about that. One of the guys from Florida presented recently on some skull-based meningiomas. I'm not sure how he gets a catheter in there because they're quite firm, but he seemed to be able to do it. So metastases, we know about 1 in 5 are radio-resistant or treatment failures, and that radionecrosis can occur and be very damaging to patients. You know, I've got a lady on this Wednesday who's really being killed with steroids. It's horrific. She's got, the steroids are doing the worst to her, I think. Many of these mets are in deep or eloquent lesions, and LIT can achieve a cytoreductive effect comparative to resection where you can't take them out. And many studies highlight the long-term patient experience as comparable, if not comparable, to open resections. In fact, all my patients thought it was fantastic, and one lady said who'd had gamma knife, had surgery, and had the LIT. She told me this she would prefer over all of them in terms of recovery. We can usually get the lesion control with a LIT, and the median time to getting off your steroids is about 37 days, as opposed to trying to manage them medically, potentially moving them over to Avastin. We can get the steroids off pretty quickly. Glioma, my colleague's done a thalamic glioma that had recurred despite all other therapy. And there's a comparison between those undergoing biopsy and chemoradiation, or biopsy and LIT, and keeping the chemo and radiation up your sleeve. And so that she had a very comparative survival. So it's another tool for small, deep lesions. Instead, difficult to access lesions like these ones, I think that that's definitely an option. But you just got to work your trajectory so you're not any more than 2 centimeters wide. You can always pull out, but you can't get any more than 2 centimeters wide with a catheter. Cerebellar lesions I haven't done, and I think my anaesthetist would divorce me if I wanted to do one of these, so I'm not going to put one on anytime soon. But certainly they have been done. So recurrent GBM, they had a survival advantage with less mortality than in the chemotherapy group, less morbidity, improved mortality. So the data is sort of robust enough for a position statement from the ACNS, and it basically is that the randomized controlled trials are unlikely to be performed due to lack of feasibility in patient-surgeon equipoise. LIT has a very short recovery time. They typically go home the next day. One of the patients I'll show, he went to New Zealand to meet to see his girlfriend 2 days after surgery, so he was really good. And the wounds are tiny. They're about 3 or 4 millimeters, and the burr hole would only be as big as the nib of a pen. And so they get out of hospital very quickly and get onto the adjuvant treatment sooner. And there's sort of a consensus that intracranial LIT should be considered in patients with recurrent or recurrent or progressive malignant tumor inaccessible to surgical resection, or where they can't tolerate surgery. And it's a treatment option for relapsed brain metastases. In epilepsy, my colleague does the epilepsy, and it's a minimally invasive option for intractable patients. So we can look at small lesions, insular. So if you can locate it with stereotactic EEG, we can look at it for that, or we can see small lesions, or amygdala hypocampectomy. They didn't get quite the seizure reduction of open surgery, but then they didn't have the problem that comes probably from sparing adjacent cortex, and they had improved object recognition and naming outcomes. So this is how they would do that. See, it's a long, thin structure, and you just gradually pull it out. So that's typically your closure. It's really very, very tiny. I just put a bit of repeat in that will fall off. So when we were trying to work out where to put it, so this one will be the first one in the Southern Hemisphere, I think. So a patient had left me some money some years ago. She had breast cancer, and I've been sitting on it waiting for something that would come that might help my patients. And so we had some money, and then you had to think about where the patients would be, because you can't really move this piece of equipment. It's quite big, it's expensive, over $1 million. You don't want to damage it. So I had to look at where there was cancer, epilepsy, and children, and also where we could treat both public patients and private patients. And that worked out to be the Mater Hospital in Brisbane. There's epilepsy there. I can take my cancer patients there, and the Children's Hospital is just next door. So the funding was the outlay initially, which I said we had quite a bit of help with donors, and also with the money that patient had left. But the consumables are expensive, and I just wanted to highlight that. A single laser catheter was $17,000 Australian. So that's $11,000 American. Now, I just want to tell you that if you get one of these lasers, that we've got it down to $7,000 American now. So you can tell them that in Australia it's 7,000 and you want 7,000, and I'll endeavour to get even better. So when I was at the Asian Australasian meeting in Jerusalem, I met Ido. So he and I had a good chat about laser, about DBS, and about facial pain, which we both have an interest in. And Ido very kindly came out to help me with the first case, and he stayed with us a little while. So this was a patient who has cancer-free, but he has radionecrosis for stereotactic radiosurgery. And really, his wife tells me he's intolerable when he's on steroids, and she doesn't want him on them anymore, but then he's not functional if he's not on them. So I actually decided that he would be a good case, even though it's not deep and I could take both of them out. I was going to treat that posterior one and take the frontal one out. So this is, so we've got a robot, and we have the O-arm and surgery. So I've got a CT the day before, and MRI, obviously. And then we fuse that with the O-arm to get our registration. Now, we don't have an intraoperative MRI, so we have to move down to MRI from there. And you can see we're positioning the robot now to get it into position. And this is the little screw that goes down into the tiny, tiny little burr hole. And you can't see. So one of the problems initially is you measure your drill for the skull thickness. So the skull thickness was 8 millimeters. So I made the drill 7 millimeters just to be sure. And it didn't go through, so I made it 8. And then it went through, but the screw wouldn't purchase. So that was my first problem. I thought, my goodness, what am I going to do? Because the screw won't get purchased in the bone. And I ended up, so I realized I can't do two burr hole, do it twice, because I just lost its thread. And so I actually anchored that first one with bone cement. Lucky it was an easy case. The next problem, this is Ido in the back here, was that it's quite hard to diathermy the dura because you can't see down there, and the Colorado needle isn't long enough. And so when I was doing the biopsy first, I realized, okay, well, the Colorado needle is long enough to go down the biopsy one. So I opened, what I thought I'd opened all the dura down this tiny burr hole, but it caused the laser to skive off. So I hadn't opened all the dura, and you cannot see that. So that was another problem, but I could resurrect it because we did a O-arm spin before we went down to MRI. So these are all the little problems that we've had. My colleague, because he learned from my case where the screw didn't get purchased, he went deeper, like he went 10 millimeters instead of 8 millimeters, just to make sure he went through the bone. But then he got a cortical vessel, so that wasn't that wasn't good. So then we have to measure it all out, and you have to protect this catheter all the way down to MRI. It does take quite a long time. You know, if I start at say 8 o'clock in the morning, we'll be lucky to be finished by 1 or 1:30. You know, the biopsy will be finished by 9, but it's all the attention to detail and looking after everything and the moving a patient to MRI and trying to get good coverage of the lesion. So this is him going down. That is the little screw holding the laser catheter in place. This is us in MRI. The radiologist is very helpful as well. They're there with us. We occupy MRI for the whole morning. So usually we have to do it on a Saturday, although they're allowing me to do this Wednesday. So I must have done something right. So, and this is the lesion. So you can see where we're heating up and what area is not dead yet. So the yellow area is dead and the pink area is about to become dead with time. And the green area is not even in the ballpark. And so the red ones are places that we don't want the the blue ones are the ones where we don't want the heat to get too high. And so we say, look, the temperature can't go above 43 in this area, and we need the temperature to hit 60 in this area. So we need tumor death. And so this is it. And there you can see my bone cement holding the the screw. But yeah, so, and this is a man afterwards. I'm just showing him. He's off steroids. He's fantastic. But I kicked straight through his forehead for that frontal one, and I think it's had a good result. So this is before on the left. You can see the radio. He's also got another one which we haven't treated, but it's not too troublesome or need steroid dependent yet. So it was all radionecrosis, no viable tumor. The frontal one's been taken out. You can see that sort of radionecrotic shape in the posterior one, and you can see the marked reduction in edema just at 6 weeks. And this lady was really interesting. So this is a lady. So she had very profound edema and was severely hemiparetic, not quite hemiplegic, but close. So she had gamma knife, ALK inhibitors for her metastatic lung cancer, and this horrific edema despite high-dose steroids. Now, it was a bit wide. It was 2.5 centimeters wide, and they tell you can get 2.5 centimeters. I couldn't get 2.5 centimeters. I thought, oh, no, I've sat down here for 2.5, 3 hours, and I cannot get coverage. But look at this. That's 6-week follow-up. It's gone, and the edema's gone. So even though I didn't get coverage, I'm delighted with that result for her. And that was the only site of active tumor for her. This is a young man, and this is the only site of active melanoma. So it's escaped gamma knife and targeted therapy. And I really didn't want to operate on that. And so it came from the front in and put a catheter in just like that. This is the one where it skived on me, but I was able to resurrect it. And this is the coverage we got. And that's him, day one post-operatively, just a little steri strip. And as I said, 2 days after surgery, he went to see his girlfriend in New Zealand, got on the plane. And this is his, you can sort of see that radionecrotic picture. This is his early MRI, so I'll see how that works out. This is one in the motor strip. I think that's actually also a case for LIT, because this is someone who has had surgery, who's had gamma knife, and I honestly think that operating on that will be pretty miserable, even with motor evoked potential monitoring. And I think she will be better off having laser. So she's going to have that this Wednesday. If she's well enough, the steroids have really, really done a number on her. So she's coming in tomorrow to have a full workup. These are ones I'm thinking about. So a deep DNET, here, and a patient who is a pilot. He's had a seizure and he can't be on anticonvulsants, so he can't work. So he's potentially coming up. Cavernomas too are on the cards. So I'm sure Professor Carter would have done a much better job than me of taking out this brainstem cavernoma. So this is a girl who nearly died about 10 years ago. And when I went in there, I came supracerebellar at it, and I thought it was all out. And the first scan looked okay. And she was, then she had another little bleed and she had gamma knife. And I encouraged her to go on and have a baby, reading the literature, saying, look, I can't find anything that says that, you were truly at increased risk. But immediately in the postpartum period, she started having repeated bleeds. And now she's got quite a severe rubral tremor bilaterally. I'm just trying to ride it out at the moment. She's, just got a little baby. She doesn't want to have any more surgery. I'm pretty scared of this one for laser for my first cavernoma, but I'm just watching at the moment. And then there's this other little one in the thalamus that keeps causing some internal capsule disturbance for a patient. Might also be another case, but she's going to gamma knife first. And that's all. Thank you very much.
Thank you so much, Professor. Beautiful talk. There was a question from Kato Sensei, yes, about the first speech.
Yeah, thank you very much. So it was wonderful talk. So I think more and more less invasive treatments in the future. I think your work is very deserved.
Thank you.
Congratulations.
Thank you.
I'll go for it more. Thank you so much.
Thank you. It's the cost that is such a problem, when there's not heaps of patients, but for those people that need it, they haven't got much else. And so, I'm very delighted to have it in an armamentarium, but getting the cost down is what I need to do. Mm.
Thank you so much, Professor Ravi.
So that was a very nice talk on DBS and lesioning part. I also always have this doubt what to do. I've done about 300 DBSs to date and a few lesionings. In fact, I had a paper which compared the two because I was trained in Canada. In Canada, lesioning was banned and then DBS came in. So there were patients who had done unilateral thalamotomies for tremor. And then we put in DBS on the other side. And the combination did work, but the thalamotomy side worked better than the DBS side. So that was my paper, which I had presented in one of the conferences in Europe. So, but the whole reason why I think lesioning is coming back in a big way is because of the advancement in imaging, in the understanding of the anatomy of subthalamic nucleus of the thalamus and things like that. So we can tailor our lesioning very well and get the outcome. But one of the reasons why I still stick to DBS and I still continue doing DBS is, one, I think the cost is slowly becoming better and the awareness is better. There are the banks in India. India is a developing country and we have also financial issues. But the banks are helping. So you can buy, if you can buy a car which costs about 15 lakhs of rupees, you can do a DBS. So there's a loan facility for that too. And the precise positioning is the most important thing. The anatomy and the precise positioning. Then you don't have issues of not functioning. And we have enough data saying that 15 years, 20 years down the line, DBS people are doing well. I have people who have come and changed the rechargeable batteries. So it's doing very well. DBS is doing very well. The most important thing is awake DBS, again, because of the homunculus and because of the variation in the nucleus from person to person. I don't believe in doing it, sleep. The other thing you showed us, the patient who had monopolar usage and then having hemibalismus. I think that was bilateral lesioning because of the hemibalismus and the battery not being switched off or put into safe mode. So that what happens with bilateral lesioning if it is not done
Yes.
very well. Yeah.
So I think as surgeons.
Yeah.
Sorry.
So I'm still for DBS than lesioning at the moment. Might change, but at the moment it's so. Thank you so much for the talk. It was very nice.
I'm just a bit cynical, I guess. I mean, I think lesioning's come back not just because of improved imaging, but where companies can make money and where they can't with radio frequency lesioning. And so I would like to see radio frequency lesioning come back.
Yeah. So I'm not putting the companies at all here. I'm just as a surgeon and for the patient benefit. So when you look at only that, I don't put the companies in place at all. So yeah, but lesioning is something that we can offer much more than we would do with DBS.
Yes. Thank you. Thank you for your comment. Thank you.
Thank you.
Thank you, Professor Ravi. Yasin?
Thank you, Professor, for a wonderful lecture. I have just one question about, did you have any case of hypothalamic hamartoma in your experience?
With lit? With laser?
Yes.
Yeah. Look, my friend who's a pediatric neurosurgeon who works next door. At the moment, they're still sending them to Texas. To be honest, when I had one look at the one they just sent, I'm kind of glad they did because it's such a horrific one. But Amelia, she's done her training too. We all had to do our laser licensing, and so she will do the children. And Jason does the epilepsy. No, I'm doing my cancer patients. So not yet. We haven't done children yet, but it's quite, to me, if you can, particularly if you could, some of the cancers, it wouldn't be all of them, but some of them you might be able to delay the radiation in those very young kids. That would be just such a huge win, I think. But you're right, the hypothalamic hematomas are definitely probably, right up there for the kids, but we haven't done one yet.
Thank you.
Thank you so much, Professor. Any other question? Okay, this is wonderful. Thank you so much. We are moving to the next speaker, Prof. Mala Bhaskara Rao, how to establish epilepsy surgery program. Is Prof. Mala around? Okay, Prof. Mala is not there. Prof. Albert Sofianov, intraventricular tumors.
I think
Prof. Albert, he's not there. Okay, now we are moving to Dr. Yasin Felici.
Dr. Albert is there.
Oh, okay.
Dr. Albert.
Yes. Sorry.
Okay.
Albert?
Sofianov?
He's there, but he's muted.
Okay.
Let me ask him to unmute.
Dr. Albert? Sofianov?
I think he's not on the computer.
Okay. Then you can continue, I think.
Yeah.
Hello.
Hello. He said hello. Yes, Sofianov.
Yes. Prof. Albert?
Yes.
Yeah, he's there. So Prof. Albert is the Chief Physician and Medical Director, Federal Center of Neurosurgery of the Ministry of Health of the Russian Federation, city of Tyumen. Professor, it's all yours.
Okay. Good day for everybody. Good day for Professor Yokokata, especially. Thank you very much for inviting me. Really honor for me. So I want to share our experience about my team from Tyumen, from Federal Center of Neurosurgery, about the intraventricular tumor surgical treatment, and about new minimally invasive possibilities about this kind of intraventricular tumor surgical treatment. So I am from Federal Center of Neurosurgery from Tyumen. Our center just this is Russia, and we stay at that midpoint of the Russia, and this is our center of neurosurgery, and we have good equipment and enough surgical experience, near the 5,000 cases per year and more than 70,000 cases totally now. hybrid operation room, laser, 3D exoscope, microscopes. Why I explain about you, because the topic of my today's lecture, intraventricular tumor, is really challenge situation, not only for patients, also challenge situation for the surgeons, and this situation is not so rare. So why for this treatment, neurosurgeons and center who treat this kind of patients must have good equipment, good new equipment with new possibilities. As the main idea, and another idea is the surgeons who made this kind of surgery must have a lot of not only skills, surgical training, but most important is anatomical training. So most of anatomical nuances must know, especially in the lab, anatomical dissections. You see our specimens, for example, from our residents for this kind of surgery. So you must know everything about the column, what presents the ventricles. So endoscopic, microscopic, and so on. You see this kind. This is endoscopic investigation, for example, of the third ventricle, and so on and so on. So why management of the intraventricular tumors in our center have some options. One of the, of course, main options is the microsurgical removing microsurgical treatment, and now we have minimal invasive, mostly neuroendoscopic or 3D exoscopic surgery, and if sometimes, if possible, for example, non-surgical treatment like radiation treatment. For an example, for germinoma and same tumors like this. Main questions: why it's possible to minimally invasive, for example, endoscopic treatment of intraventricular tumors? Why it is possible? Because we have conditions for this kind of minimally invasive surgery. So most important is as we know very well, so endoscopic or minimally invasive surgery needs large cavities. So we have large cavities. Large cavities is the ventricles. Another is most important since is we must have transparent medium just for good visualization. So cerebral spinal fluid also fill the ventricle. So why we have ideal conditions for minimally invasive endoscopic or endoscopic treatment for intraventricular tumors. And again, additionally, modern endoscopic or microsurgical exoscopic equipment and perspective we need for this kind of surgery. This is our experience. So a lot of patients with different kind of the histology of the tumors is possible for treatment for this kind of surgery. It's possible total, partial, biopsy, shunt placement, and ATV, and so on. So we made some classification for endoscopic techniques. So I divide for endoscopic treatment. We divide our approach for the monoportal and multiportal approach. It depends from the type of tumor, vascularity, size, peduncle, no peduncle, so many factors we calculate before when we choose the approach. So monoventricles is only one endoscope, and we work through the only sheet of endoscope. Biventricle is possible to 2 ports, and we work from 2 ports. And if another multiportal, if from the one ventricle 2 ports, or multiportal, or maybe a biventricle, for example. So this multiportal approach. Multiportal approach gain for us wide possibilities now, without practically any limit for the surgical treatment and for surgical remove intraventricular tumors. This is some examples of the port. Just if you want to go to the third ventricle for body lateral ventricle, the second port for the instrument, for example. Some examples of the multiportal approach. It's posterior approach, anterior approach for the atrium, occipital column, and so on.
Also, a good endoscope surgeon must have before start this kind of surgery. So we use mostly rigid endoscope, and now we widely use semi-rigid endoscope with laser possibilities, for example, and also flexible videoscope also very useful for this kind of surgery. And new possibilities in this kind of surgery because give for us new corridors, new perspective, new levels of this kind of surgery is a 3D ventriculoscope. So we use this 3D stereo vision technologies inside of this kind of visual sense 3D endoscope. It's real 3D ventriculoscope. 0 and 30 degrees is possible. And the size is a 4 millimeter size. And also another possibility now, exoscopic surgery with endoscopic assistance. And you see our operation room in this operation. So you see exoscope. This is X-Collab exoscope. And after exoscopic removal of the tumor, for example, endoscopic assistance under the exoscopic control done by me, just to see the remnants of the tumors under the corner of the exoscope, and some, for example, also possible to see some angiography and a lot of other possibilities. So it's very perspective technology, exoendoscopic surgery, also. One of the main problems in the intraventricular tumor surgery in this minimally invasive possibility is the bleeding control or bleeding management. So standard technique we know very well. This is coagulation by the mono or bipolar coagulator or laser through the one port, or some also irrigation with the warm solution. Compression by the tip of the endoscope, or maybe compression by the Fogarty catheters. Sometimes, if necessary, if big bleeding, it needs the coagulation in the dry field. So you success CSF and coagulate and work in dry field. And also small chamber irrigation technique by Henry Schroeder's development also possible. But in my place in our surgical center, we also use another additional good possibilities because we use multi-portal approach. Multi-portal approach give us some possibility to introduce some additional instrument like 90 side places laser, for example. You see on this slide, this is a 90 degrees laser backside. It's possible to coagulate very precisely and very safely. You see, another possibility is 3D endoscopy. Another possibility is possibility to use some endoclip. You see on this slide, and the clip, if a vessel is big and it's dangerous only coagulation, so it's possible place clip. Also LigaShoe, another also very safe technology. So this is how I do it for bleeding contrast. So this possibility give me another level of the intraventricular endoscopic or exoscopic minimally invasive surgery, because again stop management of the bleeding control is one of the main for this kind of surgery. So now I want to show some examples of our experience of the, for example, monoportal monoventricular approach by needle endoscope. So this is a very small patients, 10 months old male. This is neurological status. This is the complaints. So in MRI we see the tumor on the left lateral ventricular body. And with this kind of surgery, with this very small baby, we use really minimally invasive needle endoscope. You see, this 1 millimeter diameter. This is the operation sheet and other equipment. So neuronavigation system, endoscopic stand, and most important is a thulium laser. Thulium laser. This is tumor inside, and this is the skin making. You see, for the approach, this is a skin incision will be made in this place that for the ports for the endoscope. This is preoperative planning by the neuronavigation system. You see the ports if necessary. If necessary, second port is also possible. One from this point, one from this point. But in this situation, laser possibility is enough just for only one port, just from this one. This is the approach, monoportal approach. We introduce our semi-rigid needle endoscope with a operation sheet inside of the ventricle. This is a tunnel created before by the navigation probe, and it gives us possibility to put endoscope inside the lateral, very narrow lateral ventricle and the neuronavigation possibilities. Now we go inside the lateral ventricle now and expect the anatomy. Plexus corioideus is one of the main landmarks in this kind of surgery, intraventricular surgery. So I limit in the time, so I not explain before the landmark, just during the cases. And you see very well, this is a posterior monoportal approach from the occipital atrium place. You see the one of the more important landmarks of polyplexus, you see. And now we see the tumor. This is the tumor. This is anterior horn. Nucleus caudatus here, septum pellucidum on the 6th house. And you see the tumors, just color of the tumors is distinguished from the polyplexus. This is the tumor. The block just blocks the anterior horn and body of the lateral ventricle. This is left lateral ventricle. Septum pellucidum, thalamus, the bottom of the lateral ventricle. See the tumor inside. Feel the cavity. Polyplexus, tumor. And after examination of the lateral ventricle, we washing by the solution, physiological solution, and put inside the laser probe inside of the sheet by the working canal. You see the tip of the laser now inside of the ventricle and the precise visual control, endoscopic visual control. This is the tip of the laser probe. And now we targeted the point. Try to target the point for the laser vaporization. Now we start calculating vaporize the tumor. You see, very safely, very precisely, without contact of the brain of the tumor tissue, without distantly. Vaporize and shrink the tumor and remove piece by piece. Now biopsy and also remove some piece of the tumor. Additionally, you see the photos we put inside. Again, one more samples for the biopsy. And piece by piece, vaporize more and more, and totally remove the tumors. You see now, completely remove the tumors, completely deblocked the anterior horn body. Now it's empty and filled with the CSF. You see now very good orientation by the septum pellucidum, nucleus caudatus, anterior horn, and now the ventricle is collapsed after the tumor is removed. No bleeding. All structures is safe inside of the lateral ventricle. No tumor. Total endoscopic laser vaporization of the tumor. You see, before, this is after, this is total. Monoportal laser vaporization. This is histology, grade 1, corpus papilloma. Another case is a case about the biportal monoventricle endoscopic. We published this case just in this year in Neurosurgical Focus. This is 1-year-old male. You see the not small, it's really big herpes papilloma, just mainly located in the third ventricle and also grows in the both lateral ventricle through the foramen of Monroe. So this is our experience about this pure endoscopic biportal and removal of the herpes papilloma. This is 1-year-old male. You see the MRI before, big tumors. This is operative plan. This is the goal of our removal. This is biportal approach. This is tumor inside. This is endoscope. This is instrument. Again, like this. This is port for endoscope. This is port for instrument. This is first step. We go inside by endoscope just to check the situation inside of the ventricle. You see the good landmarks about like a septum pellucidum, tumors, anterior septal vein, thalamus striate vein. This is the second port we introduce. And now we introduce also through the second port we introduce ligashow instrument. This is ligashow instrument. You see the bimanual manipulation because we have 2 ports. Ligashow is a coating surface like this. Coating line. So in one session, it's possible cut, coagulate and cut. This is very safe manipulation for intraventricular tumor removal. You see, coagulate and cut in one session. This is achieved very good hemostasis. So it's possible piece by piece by ligashow remove piece by piece tumors very safely. So now with this technology, so limit of the tumors doesn't matter. Doesn't matter. This is a Ligashow instrument from second port under endoscopic control. And now remove the tumors. Again, Ligashow, this is dry field technique. You see the third ventricle now empty, tumor completely removed. No remnants inside. All veins is safe. The second stage. Same. Also shrinking tumor by the bipolar coagulation also it's possible. Cutting, coagulation and cutting, and remove piece by piece. See the total removal also. This is post-operative. No tumor inside. It's really minimally invasive, few endoscopic. 2-port you see, only 2-port. No remnants. This is another case of monoportal monoventricular endoscopic biopsy with septostomy also. You see the tumor inside of the third ventricle, so blocks the Monroe, so unilateral hydrocephalus. We put endoscope inside of the ventricle, you see. This is the tumor, and the tumor completely block the Monroe. You see the septum pellucidum, so why? As first state, we create septostomy, because we don't know it's possible for us before operation to know we open Monroe. Not possible, so why we create the septostomy like third step. This is a very wide septostomy we create by monopolar coagulation. Very easy, very safe, and very fastly. When after we create septostomy, check the patency of the stoma. It's good patency. Flotation of the edge. Now we check the situation around the foramen Monroe. And we start remove the tumors by the scissors, cutting and dissection. We use scissors not only the cutting instrument but also for dissection also. And try to open the Monroe. You see, very careful dissection by the scissors, the Monroe areas. And remove piece by piece the tumors. So we create biopsy and partial removal of the tumor also. Septostomy. This is the forming. Forming is intact after our manipulation. So the goal achieved. This is after surgery. Another one of the main options now is the microsurgical removal, of course. And of course, we have a lot of experience with the standard microsurgical approaches, but the management of the life quality and so on. So we moved to the minimally invasive possibility, like a keyhole approach also. So one of the most important things is exoscopic tubular retractor system using with endoscopic assistance sometimes in this situation. So we convert our open microsurgery to the keyhole exoscopic tubular retractor system minimally invasive treatment. This is our experience. So about patients with near the 3 years old male and with the tumor inside of the lateral ventricle, big one, so it's near the 4-5 centimeters tumors, very good vascularization. So it's not easy for the removing because possibility of the bleeding. This is equipment and setup of our operation room, and you see the two-lumen laser, exoscope, ultrasound, and brain lab, and so on. It's necessary tools for this safety surgery. So now tubular retractors become mostly popular in the surgical treatment, and we have some types of these systems. The brain pass from Nico Corporation, and this is VCOR, also a very popular system. So this is it's possible to see in this slide our microsurgical keyhole instrument. You see like this, and also this is a tubular VCOR retraction, also laser probe, and this is our equipment. This is preoperative planning for this kind of surgery. You see patient position, a position of the exoscope, not microscope, exoscope surgery. At first, localize the point of entry point by the navigation system. Skin incision, not linear, curve. They create bar hole. Then create small keyhole. Remove the bone flap. And check situation under the ultrasound control. And then create the incision of the dura for the tubular retractor insertion inside of the lateral ventricle. This is the incision of the dura. The calculation of the gyrus, top of gyrus. And under the navigation control, you see the navigation probe. We put tubular retractor inside of the lateral ventricular body under the navigation control. You see, this is a exoscopic view now, and we put retractor inside of the, just precisely inside of the trajectory, navigation trajectory inside of the lateral ventricle. And you see now the quadriplexus tumor inside of the lateral ventricle. And just to start, calculate, shrink, remove piece by piece. Now the open foramen Monroe places area, you see very well. And now next step is the remove and vaporize the tumor by the laser. It's very easy, very quick, very safe procedure. And you see no any bleeding. So it's a very safe procedure. Piece by piece, piece by piece. Through the tubular retractor. And again, no bleeding. It's completely dry field. Completely dry field, no any bleeding. So it's very good tool. save the blood is very important in this kind of surgery because the patient is very small. Irrigation and then check by endoscope the remnants. So this is not only pure exoscopic, this is exoscopic by endoscopic assistance. You see the endoscopic assistance. You see the lateral ventricles, landmarks, septum pellucidum. So no remnants, total removing. This is after operation. You see the total, no remnants. This is another very interesting case about not only lateral ventricular body, but also posterior fossa surgery. Fossa ventricle is also possible. So we share our experience about exoscopic surgery through the midline suboccipital osteoplastic craniotomy, Cobra type. So patients with 8 years old male with the tumor inside of the fourth ventricle. You see, completely filled. This is preoperative planning. You see the tumor inside. In this place, we must create the bony flap, small bony flap, osteoplastic. This is trajectory, like this. But this trajectory is possible to create only by exoscope. You see, practically parallel to the fourth ventricle flow. So by microscope, it's not possible. It's only microscope see like this. So not possible go away, but only exoscope give our possibility for real minimally invasive, creating minimally invasive approaches for fourth ventricle, because exoscope is only by exoscope it's possible to create trajectory like this, parallel for the flow of the fourth ventricle. This is our before we create, of course, a lot of cadaveric dissection to develop this kind of approach, and we try to dissect Atlanta occipital membrane. It's possible. You see, it's very well possible to dissect. And this is bony flap. This is dissected Atlanta occipital membrane. We open the Majandi. It's here. So it's only near the 1-2 centimeters only. The midline suboccipital osteoplastic craniotomy, Cobra craniotomy, like this. You see? This is our equipment for this kind of surgery, and you see the exoscope. So it's parallel for the fourth ventricle. It's possible. If necessary, more down also possible, like this. So possibility on the only of exoscope device. Skin incision is really small, just only near the 2 centimeters only. It's really minimally invasive approach. Just to dissect the muscle by electrocoagulation device. Open the occipital bone. Dissect the muscle again. Just to check the trajectory. Increase the body of the osteoplastic flap, bone flap. Create the bone flap. This is occipital bone. Dissect with the occipital membrane. and then keep away from the approach the occipital bone with the atlant-occipital membrane together in one complex. After we check by ultrasound the possibility for the approach to the tumor, and this is really small skin incision of the dura, little bit curved, just for become safe the occipital and marginal sinus to preserve it. Then dissect uvula tonsillaris fissure, just to open the Majandi foramen. You see very well. It's really good dissection of this fissure. Uvula tonsillaris fissure dissected, and now we open the Majandi without any traction of the tonsils or cerebellum and so on. It's really minimally invasive approach. And very easy, we remove the tumor from the first ventricle. And you see now it's very well, it's possible by exoscope to check even the aqueduct area. Very easy because of the possibility of the exoscope moving, head of moving. So all first ventricle is possible to check by exoscope through this really minimal invasive approach. Again, endoscopic control about the remnants, no remnants. And very easy close of the dura. No CSF in any cases. And put on the same place the occipital bone and atlant-occipital membrane to restore all anatomical structure in this area. No instability, no CSF, and really minimize whole approach, COBRA approach. This is after operation. You see the total, no remnants. It's 3D reconstruction after. So you see the all structures is restored after operation, restore. At conclusion, the minimally invasive exoendoscopic surgery helped to remove intraventricular tumors with possibility of safe surgery and gross total resection. For this kind of surgery, of course, young residents need the learning curve. And you see the example like Luis Borba teach our young residents about for this exoscopic surgery in our cadaver lab. This is our cadaver lab. So we open for collaboration. We open for the young residents. It's with the planned schedule for the this year of our workshops. Thank you for your attention.
Thank you so much, dear Professor Albert, for this comprehensive talk. Before we ask the discussant to talk, Professor, I have one small question. When you were talking about technique for bleeding control in endoscopic intraventricular surgery, you mentioned compression. How do you do that compression in the standard techniques?
This is the main two techniques. One technique is by tip of the endoscope. Tip of the endoscope. Just put inside on the bleeding to step. And another most standard is Fogarty catheter. Fogarty catheter. You feel the Fogarty catheter and press by Fogarty catheter. This is very useful because the Fogarty is transparent. So you see the bleeding point through the Fogarty.
Thank you so much, Professor.
Okay.
Now we are going to the discussion. Professor Alexandre. Is Professor Alexandre with us?
So Albert, thank you very much.
Yeah.
I want to
Good day,
ask
good day.
Hi, how are
Yeah.
you?
Okay.
Excellent skill. So just I want to ask,
Yeah, of
what
course.
is unsuitable the pathology for endoscopic surgery? Can you understand?
For suitable pathology now, very good questions. Thank you very much, Professor Kata, because when we start with this kind of surgery for intraventricular tumors, our main idea is the small size tumor before 2 centimeters, and the tumors have a good peduncle, and tumors have no big vascularization. So this is one of the most. But now, when I introduce in this kind of endoscopic surgery a multiportal principle, so it's possible to introduce inside additional instrument like a Liga show I show, and multi clips and so on. So now completely no limit. If it's possible to remove the biggest sites, and vascularity now is not so interesting because we have a laser, for example. So now it's a wider and wider indication, But most important is the peduncle and vascularity and size, of course. But if you have learning curve, so no limit.
Thank you very much. So it's a great talk.
Thank you so much, Professor Albert. Any question? Thank you, Professor. We move to the next presentation. Yes,
thank you very much.
Thank you.
Thank you.
Thank you so much. Yasin, who is going to talk about CFD application in aneurysm surgery. Yasin is from Algeria and currently fellow in neurovascular at Bantanen Hospital.
Hi, everyone. Can you see my screen?
Yes, we can see.
Yes, we can see.
Okay. So I am Dr. Yassine Félicie from Algeria. My topic today about computational.
We cannot see your slide now.
Okay.
Okay. There you are.
Sorry, I have some. So this is my home, Algeria. This is you can see my screen.
Yes.
Yes.
So this is my home, Algeria, and this is location of my hospital in Babylon City, Algiers, the capital. This is a view from above of the hospital. And this is my head of department and my mentor, Professor Abdel Halim Morsli. Now I am in Japan for my cerebrovascular fellowship in hybrid vascular surgery. Exactly Fujita Health University, Nagoya, and this is the hospital. under supervision of Professor Yakukato. I want to thank her for this opportunity. So aneurysm rupture is not 50% of patients with a brain aneurysm rupture die before reaching the hospital, and 40 people who have a brain aneurysm rupture will die, and 66 patients of the survivor will suffer permanent neurological deficit. So here we understand that aneurysm rupture is not a live complication, and the consequence is very grave. So after diagnosis modality was improved, we have many unruptured aneurysm diagnosis, and in diagnosis, now the problem is which aneurysm is stable, which not unstable. We have many modalities to, and sorry, I have to. So many tools are available and put together to try to respond to this question. We have the phase score and the aneurysm morphology and the MRI enhancement and the CFD, which is my topic today. So you can see here the air flowing around this Formula One or this plane, and the image generated through visual effect software using for films and video games, mechanical engineer, and it took pretty realistic. So behind this scene, there is a lot of mathematics and physics, computer science going on to try to solve one of the hardest equation ever discovered about the turbulent flow. And this is the computational flow dynamic application in other field. So for the equation, this is the equation, is the name is Navier-Stokes equation, and anecdote that I found that Albert Einstein start to solve this Navier-Stokes equation, but give up because it was too difficult. So CFD, the goal is a simulation, is to predict on a computer behavior of flow like water or air, as it would happen in the real world. So this, the application in aneurysm surgery, generation pass through different steps, and the first one is we have to import our DCOM file for the patient and create a reconstruction, three-dimensional reconstruction from CTA or DSA. So after that, and creating a mesh. So mesh, we have a superficial mesh and a volume mesh. And after that, we set the N-light and the out-light of branch of this region. And after that, the numerical simulation will calculate the flow and the definite domain. And the last, we have creation of image and movies to see and analyze the simulation. Finally, we have this result in Hemoscope software that we use in our department. We have many parameters to analyze. We have wall pressure and wall shear stress and wall shear stress direction vectors and streamline. So we will discuss about this parameter one by one. The first one is the wall pressure. The maximum pressure calculated as the highest area of pressure of the aneurysm wall, both spatially and temporally. So red means high pressure and blue means low pressure. For WSS or wall shear stress is a fractional force from the ball flow tangential to the area lumen. It's a relative difference in velocity between two parallel objects that create the shear stress. And we have vectors. So vector diversification corresponds to area where is the change in angle away from each other and usually seen in field wall aneurysm. For the same lines give the flow pattern of long load with the velocity comparison. So in this example, Professor Yagi put 6 cases, and the size here is similar between these domes. And the top 3 aneurysms are with this very streamlines and a high velocity. This circumstances we can call in the high flow. And in the bottom, we have 3 cases and representative for low flow. The color inside is blue, so is lower velocity. And the amount of flow rate, the apparent artery, less enter in the aneurysm. So here we have similar aneurysm morphology and the aneurysm hemodynamic different. This study here about 200 cases and unruptured the aneurysm. So x-axis show the inflow rate and the y-axis are just part of volume. What I like to emphasize out with this picture is that we see here some small size aneurysm, about 5-7 millimeter, but totally different hemodynamic. Some aneurysm at only 20% and about other about 400%. So different and less correlated with the morphology. I start some literature review here to understand better the application of CFD in aneurysm. This is meta-analysis. So the author include 19 studies that investigate WSS using CFD for geometric models and intracranial aneurysm and found that the high WSS was associated with the formation, aneurysm formation, and the low WSS was associated with a rupture of intracranial aneurysm. But still controversial about WSS signification. Multiple studies were done, and there was still no clear concordance of WSS to risk aneurysm rupture. Both low WSS and high WSS stress theory were proposed and related to rupture aneurysm. Second paper here is a good study from Dittmer and the collaborator that they study 1,060 aneurysm unruptured, and the rupture was correlated with the location, surface curvature, and the maximum flow velocity. So high flow velocity was correlated with aneurysm rupture. This paper is a Japanese study that compare growth in MCA aneurysm, about 100 aneurysm in 2 years. And the result was that growth is correlated with a high flow rate. This is typical example of high flow rate, and then this is an example of low flow rate. Another paper is about endovascular treatment and the co-organization in basilar tip aneurysm. So, here also they found that the organization was associated with a high flow rate. So here we show correlation in hemodynamic and in rupture case, growth case, and endovascular treatment outcome. So high flow rate mean what? What is the mechanism? And here comes the impingement point or flow impingement. And this case explain this. So here the point correlated in by streamlines, and the WSS and the vector direction show the impingement point. And this region is exposed the high pressure in the aneurysm. Also, Professor Yagi some years ago studied WSS vector direction in 23 aneurysms with different localization, and some with thick wall and other with thin wall. So how we can hemodynamic help us to know before surgery the morphological characteristic of aneurysm wall. And the result was very clear, which is, so the full divergent in vectors is associated with translucent part or thin part of the aneurysm. This is the impingement point. And where we have the margin or rotational vectors, here we have a thick wall or atherosclerotic wall. This study from our department, from Kato Sasaki and the whole team, about CFD analysis in the parent artery in 38 MCA aneurysm, and found that maybe we can now predict the microaneurysm formation in the parent artery behind the aneurysm. So they proposed a PARS sign, which means parent artery radiation seen, and was defined as the presence of each of the following three findings: collision of the streamlines in the outer parent artery, and the radiation outward from the wall cells vectors from the same set, and increased wall pressure compared with surrounding region. In this case, demonstrates this point in a surgical view. We have here a new formation of microaneurysm around the parent artery, what was clipped here in the surgery. Here a demonstrative case, an MCA, right MCA aneurysm, a right Transylvian approach. Here the aneurysm comes to view. We began dissecting the dome, which was this aneurysm unerupted. Dissection to see better the neck. Calculating, and now the ICG, performing the ICG. And you can see now the CFD highlighted over the ICG. When we see here, the place where the high pressure and the low WSS with diversification of vectors, this point of high flow and streamlines. Now we clip the aneurysm. The dome was excluded. The ICG control after clipping. And for this part where the high flow was very high, so we add another clip. You can see the thin wall, which was seen before in CFD before surgery. And this is the final view ICG. So finally, CFD is just a piece of the puzzle, and that we have to do more research and also consensus about CFD. Thank you. And this is the team. I finally would like to thank Professor Kato and all the team for this opportunity for me and the Young Surgeon Committee. Thank you.
Thank you so much, Dr. Yassin, for wonderful talk. You remind me a lot. I can see the big theme in the last picture. Okay, comment from the discussant, Professor Oleksandr.
Okay, thank you very much. Thank you, Yasin, for a great presentation. I'm sorry I was absent for a while due to some reasons. Very interesting method, very interesting program, very promising, promising methodic. I have some questions. One of them is, have you ever met the publication that found the correlation between the site of higher pressure, blood pressure on the wall, and the site of aneurysm rupture? Is it really the same or not? Maybe it's not. There is no correlation. I'm not sure. Maybe you have found something about this. And another question: how do you think could this method be used for prediction of hemorrhage, or at least weak locus loci for patients who are in risk of intracerebral hemorrhage due to arterial hypertension or amyloid angiopathy?
Thank you for the question. So for a site of rupture, CFD can predict the site of rupture, but with the others, I think with the others methods like recently the walls enhancement MRI. This enhancement MRI in some sequence that predict the site of rupture. There is some publication about aneurysm, multiple aneurysm, and with supraarachnoid hemorrhage, and they found that one aneurysm of this with the wall enhancement is the origin of the bleeding. So they treat directly the first one is bleeding. And CFD also can add some information about the rupture and the high pressure in this region, in the blebs. For the second question, hemorrhage.
Yes, intracerebral hemorrhage, not aneurysmal intracerebral hemorrhage. Can we use it to predict, maybe, because it's a problem?
The issue with the CFD, we have to choose one region, maybe bifurcation, or because you can't do the CFD for all, I think, for all polygon. So it takes time. So we have to select the region and do CFD for this region.
Okay, thank you.
I think maybe Professor Kato can.
Thank you very much. Thank you, because I'm not familiar with this method, so thank you.
Thank you.
Thank you so much, Professor Oleksandr. Thank you, Dr. Yassin. We wish you all the best at Bantane Hospital.
Thank you.
Okay, next speaker, I don't know if Professor Atul Goel is there, or we are going back to Professor Mala, then Professor Atul at the end. Professor Kato, what do you think?
Ek minute. Dr. Kubolo, Professor Goel is trying to join. I think we can continue with Dr. Malla Bhaskar Rao. He's not able to screen share. Okay.
Okay. So Professor Mala, good morning. According to your time there, it's 11 o'clock on our side. So welcome. Professor Mala is a professor and consultant neurosurgeon, a Department of Neurosurgery, NIM Hands, India, and past president of ISSFN. So he's going to talk about how to establish epilepsy surgery program. Professor, you can carry on.
You can see my slides and
yes, we can.
My voice. Okay, very good.
Yes.
So good morning and good evening to all of you. First of all, I'm thankful to the leadership of the ACNS for giving me this opportunity. So among all the neurosurgical procedures, anterior temporal resection for hippocampal sclerosis is one of the best procedures. Its safety and efficacy has been established in a randomized control study where almost 2/3 of the people got Caesar cure compared to only 8% with continued medical management. So one will be wondering that such a effective procedure, why it is highly underutilized all over the world. Even high income countries also, in some places there is no epilepsy surgery program, and in many of the low and middle income countries it is not existing. If you take India, for example, we have 1.4 billion people are there, and more than 5 million people with active epilepsy, more than 1 million people who require evaluation for epilepsy surgery, and at any given time there is a 250,000 potential epilepsy surgery candidates are there, and at present about 1,000 epilepsy surgeries are happening per year in India. If you take Africa, Africa also has got close to 1.5 billion people, and with the prevalence and incidence of epilepsy studies in Africa, it is estimated that there are nearly 1 million people with temporal lobe epilepsy, and again 250,000 people with who are potential surgical candidates. There are anecdotal reports about the epilepsy surgery procedures in Africa, but overall the number, I'm sure some of you may be familiar with the published literature. So it's a challenge to develop epilepsy surgery. In fact, there are 3 major global challenges are there. One is, of course, to develop epilepsy surgery, new epilepsy surgery programs. A second one is to expand and improve the existing epilepsy surgery programs. And of course, the third one is more academic epilepsy surgery programs, where in addition to service, a lot of training as well as research is being carried out. More than 2 decades ago, the International League Against Epilepsy came forward with the set of framework and guidelines how to start basic epilepsy surgery centers as well as academic reference centers. Let me take you through the Indian experience. I had a historical opportunity to perform the first hippocampal resection in India in mid-90s, in 95, at Sri Chitra Tirunal Institute in Trivandrum, Kerala state in southern India. Over a period of time, this program heavily based on non-invasive pre-surgical evaluation and standardized epilepsy surgery procedures became a model for developing world. Dr. Radhakrishnan, me, and many of our colleagues in India actively went and assisted young neurologists to read about video EEG, learn about video EEG telemetry, and then young surgeons to initiate epilepsy surgery programs across India through a voluntary group called National Epilepsy Surgery Support Network initiative. And several barriers existing in India were broken to popularize epilepsy surgery. And my colleagues have done a survey recently and found that across 60 centers, more than 12,000 epilepsy surgery procedures were performed over the last 28 years. And the published outcome across these centers is at par with any other established center in the industrialized world in Europe and in the United States and other established programs. So in India, the good thing is that the basic knowledge about epilepsy is included in the undergraduate curriculum, MBBS curriculum, and it is expanded further in the postgraduate program MD as well as super specialization called DM neurology. And the postdoctoral fellowship is there are about 50 neurologists gone through this program across several centers in India, and they get focused training on both video EEG telemetry and pre-surgical evaluation, as well as post-surgery follow-up of these patients. So these are all the institutions which are offering fellowship in epilepsy and epilepsy surgery across India. And some of the overseas candidates also came to India for these fellowships. Not only service, outstanding clinical and basic science research work is happening. This is a randomized control study about efficacy of surgery, epilepsy surgery in children, which came from All India Institute, New Delhi. And this is from our center, NIMHANS Bangalore, about magnetoencephalography in the pre-surgical evaluation, especially identifying the high frequency oscillations. These are the Scheser origin zones. Eventually, several minimally invasive procedures, including laser ablations and RF radio frequency ablations, will evolve to create thermal lesions over these high frequency oscillations zones. So Scheser origin is taken care so that there will be no further propagation. And the colleagues from Sri Chitrathirunal Institute in Thiruvananthapuram, they came with guidelines regarding how to taper and stop anticonvulsant, anti-Scheser medication following successful surgery. So based on our experience as well as published literature, we can say that the success of epilepsy surgery depends upon the accurate localization of the epileptogenic zone, and the success depends on early identification as well as identifying the ideal surgical candidates. And there are two basic requirements for considering establishing epilepsy surgery program. One, there should be a medical infrastructure where a large number of people with health problems and medical problems and epilepsy come for initial screening. So the infrastructure should be able to identify people with epilepsy and then people with drug-resistant epilepsy, and then refer those people with chronic drug-resistant epilepsy for a detailed evaluation to comprehensive epilepsy care programs where multidisciplinary teams and evaluation is available. And there are three basic requirements. Of course, there's a need for infrastructure and technology, but soon people realize that the investment in infrastructure and technology is in fact very minimum. To start basic epilepsy surgery, only two things are required. One is video EEG facility to identify the Scheser classification and then localization, and then of course MRI to find the lesions. So we need infrastructure to identify the focus and lesion. And of course, from surgery point of view, microsurgery, microscope, as well as basic microsurgical instruments, that's all is required to start, initiate the basic epilepsy surgery. Of course, when the programs are being expanded and improved, there is a need for functional imaging and invasive evaluation, as well as very innovative neurosurgical procedures. But the real investment is actually in people. There is a need for a motivated team with a strong team, motivated team leader. And in countries with limited resources, where medicine is practiced largely on an individual basis, forming these teams is not easy. Also, once teams are formed, identifying epilepsy surgery candidates also is not easy. See, the potential epilepsy surgery candidates are hidden in the community among hundreds and thousands of other people with various types of epilepsies. If you take the case of mesial temporal lobe epilepsy, after the initial insult, like birth trauma or febrile seizures, for a long time, nearly 10 years, there is a silent period. Actually, it is not silent period. This is a period of epileptogenesis, where the seizure focus is forming and maturing. And then initially, these epileptogenic neurons, they respond to anti-seizure medication. So families, physicians, pediatricians, all of them keep trying to use medication in various permutations and combinations, spending almost 10 years, 15 years, 20 years. So only when people are in late 20s and 30s, then only they come for surgical intervention. And when we do surgery and cure epilepsy in these people in the third decade, they already lost schooling and opportunities for employment and even to get married. So what we are doing is too little and too late. So even when these people come for evaluation, even for a neurologist, it's not easy to identify ideal epilepsy surgery candidates. The temporal lobe epilepsy is actually a group of disorders. There is a mesial temporal lobe epilepsy. There is a lateral neocortical temporal lobe epilepsy. There is a temporopolar epilepsy. There is a orbitofrontal epilepsy. There is a occipital epilepsy. There are insular epilepsy. All of them look like similar. So it needs an experienced epilepsy neurologist to sort out all these candidates and then identify the ones for pre-surgical evaluation. Even when they come with lesions like this, see this two people with two different lesions. What to do with these people? Just lesionectomy alone? Is it adequate, or is it detailed pre-surgical evaluation? And epilepsy surgery is required, needs a great amount of pre-surgical work. For example, this lateral neocortical lesion, if it presents with few seizures and short period of epilepsy, probably lesionectomy is adequate. But if the same patient presents with 4 to 5 years of history of seizures and then 100 to 200 number of seizures, probably surrounding area, all the hemosiderin-laden area has to be resected. If the same patient comes with 20, 25 years of chronic drug-resistant epilepsy and semiology, if it is suggestive of mesial temporal involvement, we have to do detailed pre-surgical evaluation and then find out whether hippocampus has taken over as the source of seizure origin. And then surgical strategy should include the resection of the hippocampus also, in addition to the lesion. So it's a clinical presentation. it's the seizure duration, seizure severity, seizure semiology, drug responsiveness. Number of factors will influence the surgical strategy. So pre-surgical evaluation, of course, is based on two cardinal principles. One is concordance. Everything should come from the same area, lesion, focus, functional deficit, all should be in the concordant area. And this concordance has to be established with using minimum amount of resources and investigations. Of course, surgeons should contribute to pre-surgical evaluation also, should not be contributing only, should not be limited to technical contribution, just removing the hippocampus. Young surgeons who are hoping to become epilepsy surgeons should know about epilepsy, should find out whether a person referred for surgery has got focal epilepsy, has got, for example, one who was sent for anterior temporal resection really has got a temporal lobe epilepsy confined to temporal lobe, especially mesial temporal lobe. Is it drug resistant? What is the focus? What is the lesion? What is the optimal strategy? What are the likely outcomes and likely complications? All these things have to be discussed, of course, in a patient management with a multidisciplinary team, but surgeon should also make an active contribution. Of course, once the program starts, there will be large number of people opting to undergo evaluation and surgery. They can be easily formed into these various groups. You see, if you look at this data, you see outcomes, the best outcomes, the seizure cure depends only on two factors. One is vary the lesion focus and what is the procedure which we are going to undertake. For example, if it is a hippocampal lesion and if you do anterior temporal resection, the outcome is outstanding and it's a very minimally invasive or non-invasive evaluation and then standard surgery. So this is where all the beginning programs should start, and stepwise, as they accumulate more experience, they should resort to more and more difficult cases, and then finally resorting to this sort of disconnection as well as neuromodulation procedures, or they can simply refer them to more advanced and academic centers. Of course, with experience, these institutions eventually can take more extratemporal neocortical epilepsy, where very complex and innovative pre-surgical evaluation as well as surgical strategies are required. So the technology in neurosurgery, technology in epilepsy surgery is changing. Now laser ablations and thermal lesions is being done instead of large resective surgeries, and virtual models are coming up, like after stereo EEG implantation, you can build a model and then do virtual surgery and then see the outcome before actual taking up the real surgery. And of course, neuromodulation is coming up in a big way. Of course, in many of the low and middle income countries, cost will be a limiting factor in the near future, but hopefully in the next 2-3 decades, neuromodulation procedures should be available worldwide to the deserving patients. So all these procedures have got risk factors based on the substrate involved and anatomical location. And of course, we have to do our utmost to avoid and minimize these complications. And one very important contribution which academic centers worldwide are doing is using the epilepsy surgery specimens to understand the basic mechanisms that why some people develop drug-resistant epilepsy and what is actually happening when drugs are being given to these lesions, like they develop resistance. The drugs will be cleared very quickly, and what sort of drugs are more effective. All this work is happening. In fact, the resected hippocampal as well as neocortical dysplastic cortex. These specimens, they're like gold mine. So those who have resources should do intensive research, and those who do not have the resources should share their specimens with other centers and then contribute to the research. European Brain Bank has collected 12,000 epilepsy surgery specimens, and data analysis from the European Epilepsy Surgery Brain Bank gave rise to new classification of dysplasias. Like now glioma classification has got a genetic component, like that dysplasia component also, dysplasia classification also has got a genetic component, and which is going to be published in a year or two. And this European Brain Bank also contributed to optimum anti-seizure medication, as well as a reduction of outcome classification, as well as a reduction of anti-seizure medication. So I know that colleagues in Africa have initiated epilepsy surgery programs and then published, at least I came across half a dozen publications, much in collaboration with established centers in the Western world. But maybe in the continent itself, every country can have an epilepsy surgery program, and maybe one or two academic epilepsy surgery centers where they can collaborate and then conduct workshops, training programs, demonstration, epilepsy surgery demonstration projects. And then with this sort of collaboration within Africa, I think probably the number of colleagues trained will be high, as well as the training methods will be more local methods, and of course large number of people with drug-resistant epilepsy will benefit. And of course they can always utilize the expertise and resources of the professional organizations. For example, International League Against Epilepsy has got a task force for supporting epilepsy surgery in the low resource settings. And there are a lot of educational resources are there. Excellent illustrative cases are there. They're all archived. They're all archived in the ILI website. And in coming January 2024, the first International Epilepsy Surgery Society Congress is going to be held at Dubai. We invite African colleagues to join this meeting, and of course, the World Congress is being held in Africa. So I think there are a lot of opportunities for collaboration and expanding and improving the epilepsy surgery service in Africa. The burden is enormous, and unfortunately, a substantial number of patients do not receive any appropriate treatment, and this treatment gap can be minimized by educating the primary care physicians, especially pediatricians, referring doctors across the African continent. We have proven in India, in China. China has got very robust epilepsy surgery program. Every province in China has got epilepsy surgery program, and Africa is in the process of developing several such centers. So hopefully with all these endeavors, initiatives, let us hope that lives of hundreds and thousands of people with epilepsy will improve in the years to come. Thank you very much for your attention.
Thank you so much, Professor Mala. Excellent talk. Now we ask a discussant to Professor Abidasha. Do you have any comment?
Yes, Dr. Kubalar. Dr. Rao, that was a fantastic presentation, and we should all learn to, get into the epilepsy programs, have more programs at various institutes so that we can treat this disease more effectively.
Thank you.
Thank you so much, Professor Abidasha. Any question from the audience?
I think
question for the panelists?
Professor,
Sorry? Yes, Professor.
Professor Kato wants to ask something.
No,
yes,
it's
Professor
fine.
Kato.
No, it's excellent talk. Thank you very much. I think you can embed more in Africa. I think you can teach more educational course or workshop or webinar to the youngest, the next generation doctors, please. Thank you very much.
Thank you. Thank you.
Thank you, Professor. Thank you, Professor Mala, for that brilliant talk. Now we are moving to the last presentation by Professor Atul Goel, Professor and the head of the Department of Neurosurgery, King Edward Memorial Hospital, and Seth GS Medical College. And he's also Chief Neurosurgeon, Tata Memorial Hospital and Cancer Research Institute in Parel, Mumbai, India. Professor is going to talk about vertical spinal instability, introduction of a concept. Professor, welcome.
Yes, thank you very much. Can you hear me? Can you hear me?
Yes,
okay?
We can hear you. We can see your screen.
Okay. So I'm sorry that there is some miscommunication. Hi.
Hi.
It is my great pleasure and big honor to participate in this program. Yoko Kato, my dear Professor Yoko Kato, thank you very much.
Thank you so much.
And it is my, to relay my message to Africa is my great opportunity. I want to only let you know that I wish to present a complete different kind of spine surgery. I want to present a complete revolution in spine surgery. And more I work on this subject, more and more I travel on this road. I realize that this is the road to success in spine surgery. So this is the confidence with which I am coming to you, my dear friends from Africa. I am saying we should not always talk about decompression. Next slide, please. Next. Dr. Abida is turning the slide, so go back. So I wish to introduce to you a concept. If you talk to all spine surgeons of the world, the main issue is compression. I'm saying that compression is not the issue in spine surgery. Compression is not the problem in spine surgery. Compression is always secondary. Compression is always adaptive or protective. Compression is indicator of segmental spinal instability, and compression, most importantly, is reversible after spinal stabilization. And the other issue is decompression, which the whole world of spine is doing, is not the treatment for spine surgery.
I think he is just logged. There's some connection problem. Just give me a minute.
Okay. Sorry, there is some issue here. Can you hear me, Abida? Okay.
Yes, sir.
So with this controversial, this revolutionary concept that compression should not be the only issue. We should not think about compression. We should not think about decompression. The issue is instability. The human body is different from all other animals. We are standing human position. We stand on two legs, and all our muscles are focused on the back of our spine. And when these muscles become weak, there is instability of the spine. And this instability of the spine is very common in human beings. It is not so common in flying animals or in four-legged animals. It is common in human beings. And all our muscles which take part in our standing position are focused on the facets. The facets of the atlantoaxial joint are round and flat because they give circumferential movement. The facet of subaxial spine are vertical. So when there is weakness of the subaxial spinal facets, there is listhesis of the facets. The facet, there is a listhesis. And this listhesis is vertical spinal instability. And this listhesis is the point of genesis of spinal spondylotic disease. And when this weakness is at the craniovertebral junction, there is a circumferential kind of instability, which we have labeled as central or axial spinal instability, atlantoaxial instability. When the instability is of chronic nature, when there is instability of 10 years, 15 years, 20 years, there are lots of natural reparative processes which look like pathological but are secondary. They are protective and they are reversible. When there is chronic atlantoaxial instability, chronic for 15 years, for 20 years, there is shortening of the neck, there is torticollis, there is basilar invagination, there is syringomyelia, there is external syringomyelia, there is kyphoscoliosis, there can be C2-3 fusion. All these things which are mentioned are considered currently in the literature as pathological, as problem. And for all these problems, decompression has been the treatment. I am saying that all these issues which are mentioned here are secondary, and they are secondary to atlantoaxial instability, and atlantoaxial stabilization is the treatment. Decompression is a negative form of treatment. For the first time in literature, we said that basilar invagination is of two types. One is when the odontoid goes up and when the tonsil comes down. We said that transoral decompression is not the issue. This is an unstable spine. Open the joint, distract the facet, reduce the atlantoaxial instability and basilar invagination, and do craniovertebral junction realignment. For group, we had said in 2004 that do foramen magnum decompression. Axial stabilization, and you see a magic. So this kind of basilar invagination, open the joint, distract the facet, and reduce the instability. See, there is some discoordination. I want you to go fast. You see this basilar invagination, the whole world was doing transoral decompression earlier. So we have said that open the joint, distract the facet, reduce, and decompression should not be done. Instability is the issue and stabilization is the treatment. Basilar invagination, instability, and stabilization. Transoral decompression, we have completely removed and sent it to historical domain. We have said transoral or transnasal or endoscopic decompression should never be done for basilar invagination or for any issue related to instability. C1, C2 instability or listhesis is a vertical kind of instability due to weakness of muscles of the nape of neck. It is equivalent to listhesis of lumbar sacral region, L5 over S1 listhesis. We have said that listhesis is the issue, instability is the issue, and stabilization is the treatment. No need for anterior decompression or posterior decompression. So we have introduced a new entity called central or axial atlantoaxial instability. Believe me, my friends, understanding of this atlantoaxial instability of a chronic form can revolutionize your treatment for Chiari malformation, for syringomyelia, for platybasia, for degenerative diseases, for OPLL, for Hirayama disease, and a number of clinical issues. So this is my classification of atlantoaxial instability. Type 1 is when the facet of atlas is dislocated anterior to the facet of axis. Listhesis is the issue, stabilization is the treatment. Type 2 is when the facet of atlas is dislocated behind the facet of axis. There may not be any disturbance of atlantodental interval. There is no compression of the odontoid process over the neural structures. Even when there is no compression, instability is the issue and stabilization is the treatment. Type 3 is when the facets are in alignment. When there is no atlantodental interval disturbance, but presence of Chiari, presence of secondary manifestations of chronic instability like Chiari, syringomyelia, platybasia, assimilation of atlas, C2-3 fusion, they indicate atlantoaxial instability. The beauty is when you see these anomalies, you should think about not decompression, but atlantoaxial stabilization. So basically, basilar invagination, instability is the cause and stabilization is the treatment. So we have written several articles where we have said that for both group A and group B, you need to do atlantoaxial stabilization. So this kind of Chiari and syrinx, you look at the facets. Facets may be having malalignment. There can be retrolisthesis of the facet of C1 over C2. There may not be any compression by the odontoid process. There may not be any atlantodental interval disturbance. Do atlantoaxial fixation. There is no need, absolutely no need to decompression. Even when the facets are in alignment, stabilization is the treatment. And believe me, my friends, magic is the clinical outcome. This is another slide. You see, there is no atlantodental interval disturbance. There is some facetal malalignment, no decompression, do atlantoaxial fixation. So my concept is now very, very clear. For Chiari, for syrinx, even when there is no atlantoaxial, no facetal malalignment, no atlantodental interval, presence of Chiari, presence of syringomyelia, presence of basilar invagination, whether basilar is present with syrinx or without syrinx, atlantoaxial fixation is the treatment. Syringomyelia will reduce in 100% of patients when you do a scan after about 3 months or 6 months. Whether the syrinx reduces or not reduced, in the immediate postoperative period, magic is the clinical outcome. Absolutely new person you can see. By decompression, you can never see a magic. So basilar invagination, syringomyelia, Chiari malformation are all secondary to chronic atlantoaxial instability, and stabilization is the treatment. So we introduced this article about few years ago where we showed our result of only fixation for all kinds of Chiari malformation and syringomyelia. I wish that you please read this article of mine. When the Chiari fails, this patient had undergone 13 operations, ventriculoperitoneal shunt, syringosubarachnoid shunt, foramen magnum decompression, and all these kind of things. You do atlantoaxial fixation and you see an absolute magic following surgery. So Chiari is secondary to atlantoaxial instability. Chiari is protective. Chiari is reversible. Chiari is a formation and not a malformation. Syringomyelia is secondary to chronic atlantoaxial instability. When syrinx is present with basilar, without basilar, it is atlantoaxial instability. Idiopathic syrinx, when syrinx is present without any other abnormality, look at the facet, look at the instability. Don't do syringo-subarachnoid shunt, do atlantoaxial fixation. And I can only tell you a fascinating result can be produced following C1, C2 fixation. Cervical fusions are also related to chronic instability. Cervical fusions are protective and they are reversible, potentially reversible following atlantoaxial stabilization. In this case, if you see, there is no compression opposite the odontoid process. No neural compression, but you see multi-segmental spinal bony fusion. These are indicators of one issue, and that issue is atlantoaxial instability. Stabilization is the treatment. Bifid is secondary. Bifid is protective. Bifid is indicator of unstable atlantoaxial joint. Bifid, one treatment, atlantoaxial stabilization, not decompression. Os odontoid, this kind of, you see the multi-segmental fusions, multi-segmental bone complete fusions. Bifid is indicator of one issue. Even when there is no compression, C1, C2 fixation is the treatment. Os odontoideum is secondary. Os odontoideum is secondary to chronic atlantoaxial instability. It is an indicator of unstable atlantoaxial joint. No decompression, no from front or from behind. Do atlantoaxial stabilization. That is the treatment. Short neck, torticollis, short spine, short body height are all hallmarks of chronic atlantoaxial instability. Atlantoaxial stabilization is the treatment. No decompression of any kind is the treatment. So when you see these kind of children with short neck, short spine, torticollis, there is only one treatment in the world that is a treatment. No hypothetical issue should be considered. Do C1, C2 fixation. And I have to tell you that magic will be the clinical outcome. This was my article where we said that all musculoskeletal abnormalities can be reversed following atlantoaxial stabilization. And you can give a beautiful smile to these patients. Next slide. And you see this child, neck is straight in the immediate post-operative period, no osteotomy, no decompression. Only stabilization was done as a treatment. Kyphoscoliosis, when you see Chiari syringomyelia with kyphoscoliosis, when you see kyphoscoliosis alone, when you see Chiari alone, when you see syringomyelia alone, see, these are manifestations of chronic atlantoaxial central instability, and atlantoaxial stabilization is the treatment. And I have to tell you that the kyphoscoliosis can return to normal, breathing can return to normal, symptoms in the hands and legs can become normal, and you can have a magical clinical outcome. So central instability can by itself be a cause of chronic cervical myelopathy, and you can have patients who have myelopathy, they are undiagnosed. You see, in this patient, there is no compression at the craniovertebral junction. The facets are in alignment. There is no atlantodental interval disturbance, but the presence of bifid, presence of syringomyelia are indicators of unstable atlantoaxial joint, and stabilization of atlantoaxial joint is the treatment. So foramen magnum decompression, in my estimate, can become a historical operation. There is no question in my mind. So now I'm wondering whether I have time, Dr. Abida, or no? So now
Yes,
present.
you can continue, please.
Okay, thank you. So I now want to go to another very fantastic revolution in spine surgery, spondylotic myelopathy. Everybody in the world is doing spinal spondylotic myelopathy. I was doing anterior surgery for many, many years, and this was my chapter in Schuit and Schmidt. And this kind of anterior decompression, anterior corpectomy, anterior instrumentation, I was doing on a regular basis. And these instrumentation, we all know how to use them and what to do. And these tricortical screws, I had described these were as for the first time in 30 years ago as stand-alone kind of fixation. So to tell you that I was very good in anterior surgery, but now my concepts have changed. My concept is that disc is not the issue. Disc is divine. Disc is protective. This can never go wrong. All the muscles are focused on the facets. And when these facets become weak, there is a listhesis at the facet. And that is the issue of spinal spondylosis. When there is listhesis of facet, there is vertical spinal instability, degenerative arthritis of the craniovertebral junction. Nobody in the world talks about it. There is degeneration and there is instability. So this was the first article in the literature where arthritis was related to an unstable atlantoaxial joint and stabilization was considered to be treatment. Reduction in the joint space, buckling of the posterior longitudinal ligament, osteophyte formations are not primary process. They are vertical instability. They indicate unstable spine. They indicate that you should stabilize. They indicate that stabilization is the treatment. Decompression is not the treatment. Presence of osteophytes in front of the odontoid process, behind the odontoid process, on the tip of odontoid process are all indicators of unstable atlantoaxial joint. Stabilization is the treatment, no decompression. Retroodontoid pseudotumor is like an osteophyte, is like an OPLL. It is indicator of chronic unstable spine. And for the first time in Japanese literature, we said that retroodontoid pseudotumor is an indicator of unstable atlantoaxial joint and stabilization is the treatment, not decompression. So this was a remarkable change from the existing literature at that time. Retroodontoid cyst. The whole world will like to open the cyst. I am saying cyst is secondary to chronic instability. Stabilization is the treatment. And the cyst can disappear in the immediate postoperative period. And this is another cyst. You see the atlantoaxial facets are unstable. There is central instability. You stabilize and the cyst will disappear. Cyst removal is not a difficult job, but it is not necessary. So we wrote this article on retroodontoid pseudotumor and cyst and pannus, and I wish that you please read it. And I want you to read it in Africa. Retroodontoid pannus, the whole world was doing pannus in rheumatoid disease. The whole world was doing transoral surgery. We said it is due to vertical instability, vertical collapse. You do stabilization and the pannus will disappear in the as soon as in the immediate postoperative period. So we introduced these intra-articular spaces for distraction, reduction, and fixation about 30 years ago. I must say that I don't use them now too often, but this was the article that was published on joint jamming and spacers. So we have learned about C1, C2, but we have not talked about subaxial facetal listhesis. All our muscles are focused on facet. The facets are oblique. And when these muscles become weak, there is joint reduction and facetal listhesis, which leads to vertical facetal instability. And that is the point of generation of spinal spondylotic disease. We should look at the facets. We should not just concentrate on the disc. We should not concentrate on the compression. What is important is look at the facets. If you carefully see this slide, reduction in the interbody space, bulging of the disc in the lumbar spine and in the cervical spine, this bulge and ligamentum flavum buckling and osteophyte formation, these are not primary issues. They are secondary. They are indicators of unstable spine. They are indicators of instability of the spinal segments. They indicate the need for spinal stabilization and not decompression. So this is vertical instability is the issue. And we have to understand this concept. So about 15 years ago or 20 years ago, we introduced the concept of facetal distraction using spacers. You distract the facets and there can be immediate reduction in the osteophyte and there can be immediate resolution of the spinal compression. So at that time, we did for many, many cases of spinal ligamentum flavum buckling, bulging of the osteophytes, reduction in the joint space, compression of the cord, and various issues. These kind of intra-articular spaces we did, and we saw the immediate result. You see increase in the disc space height, debuckling of the ligament, osteophyte, and the ligamentum flavum. So this was a very effective technique. For the first time, we said that you can do it for multiple segments and no decompression, but distraction is the treatment. And arthrodesis or joint fusion, not decompression, fusion is the treatment. And we did, you see here, this is the multi-segmental spinal degeneration. If you ask me what is the main issue in spinal degeneration, is to identify which segments are unstable and which segments need stabilization. So this was my technique several years ago. I must say that I have now graduated from this technique. I don't use this technique too often, and then I will tell you which technique I use now. So this was the first article in the literature where we said that decompression is not the treatment. Decompression is not the treatment in spinal spondylosis. Secondary decompression and stabilization, and we introduced a new concept of spinal degeneration. And these were my spacers, which I used about 20 years ago. And you see, this is another case where I use the spacers, and you have immediate post-op, the osteophytes disappears, the disc space reduction, increase in the disc height, increase in the foraminal height, and fusion and arthrodesis is the result. We use the same concept for lumbar spine. Lumbar canal stenosis is not a primary issue. It is secondary to multi-segmental spinal instability, and distraction is the treatment, reduction, arthrodesis is the treatment. And this was my article published in Journal of Neurosurgery several years ago. As we go further in this business of spinal decompression and fixation, we have realized that not even secondary decompression is necessary. Instability is the issue and stabilization is the treatment. So in 2013, we introduced the concept that no decompression, nor primary decompression, nor secondary decompression by facetal distraction. Only fixation is the treatment. So this was my article in 2013, and this was my recent article in 2020, where we said that this was in World Neurosurgery, where we said muscle weakness related spinal instability is the issue in spinal degeneration, and spinal stabilization is the treatment, not decompression. So we did many, many cases. And if you see, there is severe compression of the cord, no decompression was done, only fixation. And after 18 months of surgery, you see the entire spinal canal, all the osteophytes are finished, and there is a new spinal cord. More important than anything else is the remarkable clinical recovery that you see in the immediate postoperative period. Next slide, please. So degenerative myelopathy, we should look not in the perspective of compression, but in the perspective of instability. Not decompression, but stabilization. Instability is the cause of symptoms. Stabilization is the treatment. And this is a very remarkable revolution in the field of spinal degeneration. Next slide, please. Most important issue, as I mentioned, is which are the indicators of spinal instability. You have to identify, not from radiology, which segments need stabilization is the most critical issue in degenerative spinal diseases. In this slide, if you see, there is only 2 segments of osteophytes and ossified ligament, but I have done 4 segments of stabilization. And you see, after 16 months of surgery, the entire thing has disappeared. Now, why I have done 4 segment fixation for only 2 segments is the critical issue. And you have to read my article as to what are the features that identify unstable spine. This is 3-level issue, and I have done 4 segmental stabilization. Very important to understand which segments have to be fused and which segments have not to be fused. You see the result after about 2 years of surgery. You see this another patient, complete resolution of compression. So over the years, I have done several cases where I have not done any decompression, and magic is the clinical outcome. That you have to understand and realize. Most important issue is which segments have to be fused. Other issue is atlantoaxial instability can also be associated with subaxial spinal instability, and you have to include atlantoaxial joint in the fixation construct. If you see here, there is no compression by the odontoid process, but there is central atlantoaxial instability. You have to include atlantoaxial stabilization in the fixation construct. When there is severe atlantoaxial, when there is a severe myelopathy, patient comes on a wheelchair, patient comes on a trolley, atlantoaxial instability is more often than not associated. You have to include atlantoaxial joint in your fixation construct, no decompression. We introduce an alternative technique of C1, C2, C1-2 stabilization by avoiding the C1 facet and including C2-3 transarticular fixation. So this is I wish you read my article. Most important is that atlantoaxial stabilization with subaxial stabilization is necessary in multi-segmental spinal degeneration, and there is no role or a negative role of decompression as a form of treatment. Same concept we talked about for lumbar canal stenosis. Lumbar canal stenosis means the whole world wants to decompress. You see this article in Neurosurgical Focus where we said that it is not a stenosed canal, it is an unstable canal. Decompression is not the treatment. Stabilization and multi-segmental stabilization is the treatment, and this can produce a magical clinical outcome. For lumbar canal stenosis, the whole world will do decompression. I am saying that decompression is not the issue. Decompression is not the treatment. Decompression is a negative form of treatment. Stabilization is the treatment. I use transarticular method of treatment fixation, which is strong, which is solid, which is safe, and which is lasting, and which is fantastic and wonderful. So over the years, we have published several articles on the subject, and we have said that you have to do stabilization and not decompression for cases with lumbar. You see, there are several things on this subject. Presence of bony fusion, presence of evidence of fusion, presence of osteophytes are indicators, are evidences of unstable spine. Osteophytes are secondary. They are protective. They are reversible. They need respect, and they do not need demolition. Stabilized osteophytes will disappear. And this was our article we published several years ago, and we discussed the outcome of only fixation. And as I've shown you in several pictures, osteophytes disappear. When their work is done, when the spine is stabilized, they disappear. They resolve. They are natural protection. They are beautiful, divine intervention, and they are not harmful. They are not monstrous. They are reversible and protective in nature. So we should not call it stenosis. We should call it unstable spine. This is a misnomer. Deformities are not primary. Spinal deformity, the whole world is doing corpectomies or kyphectomies and things like that. I'm saying deformities are secondary to unstable spine. You identify which segment is unstable. Many a times you will find atlantoaxial instabilities. Several times you will find central atlantoaxial instability. You stabilize and you find a magic treatment. So for deformities, I do not recommend any kind of bone work. I do not recommend any kind of decompression. I recommend stabilization. And you see how much different it is from the world literature. Prolapse disc, the whole world wants to do discectomy by endoscope or by microdiscectomy. I'm saying sudden lifting of weight can damage your ligaments and create instability. So disc herniation is secondary to unstable spine, or unstable spine is the cause of disc herniation. When you see a single level disc, the whole world would like to remove the disc. But I am saying this is not, you put a collar, there will be no pain. You don't move your neck, there will be no pain. but you cannot put a collar for a long time. You stabilize the spine, the disc will disappear, the pain will disappear instantly, and the spine will recover to normalcy in about 2 or 3 months of time. The disc resorption. So facetal fixation is the treatment for cervical radiculopathy, not decompression, not discectomy, not anterior surgery. And same is the treatment for lumbar spine. What you have to do is stabilization, and there is no need. So this is quite a revolutionary kind of treatment which I am propagating to you, but I can only tell you, you have to believe what I am saying. This is complete variation of what is normal, what is described in the literature, and it will produce tremendous results that you have to see. So there are many cases we have done for such large disc only fixation. As I have mentioned repeatedly, that the only treatment that the only thing that you have to identify is which segments are unstable and which segments need. So if there is one segment of disc herniation, I have done 2 or 3 levels of stabilization. This is the most, I wish that you please read my article on this subject to find out when and how I do and what I do. This is a multi-segmental ossification. This is the last chapter of my presentation, ossification of the posterior longitudinal ligament. It is the most difficult chapter in spine surgery. Bone present in front of the cord is the most dangerous issue. Decompression is not easy in such a situation. Decompression is dangerous in such issue. My concept is, you see, I was doing decompressions for a long time for OPLLs. I introduced the concept of oblique corpectomy. Oblique corpectomy was first introduced by me several years ago, but now I say that corpectomy, whether oblique or whether complete, is not the treatment. It is not necessary. Decompression of any form is not necessary. Only stabilization of OPLL is the treatment, and I've been doing for several years. And there are several articles of mine that discuss about only fixation as the treatment for cervical myelopathy related to OPLL. And I wish that you please read these articles because it is propagating a new concept, a new theory that OPLL is not due to regional issues, not due to dietary issues, not due to genetic issues. It is secondary to unstable. Chronic instability is the issue. You focus on the facets. You will fight facetal instability. You do stabilization. And I have to tell you, believe me, a magic is there for you to see. Atlantoaxial instability is very commonly associated with OPLL, and you have to do atlantoaxial stabilization in addition to subaxial stabilization, which is mandatory and which is, as I have said repeatedly, an absolutely gratifying clinical outcome you can find, which no kind of decompression will ever give you. If many of you are treating OPLLs, you know how much complications can happen. Patients can be devastated by complication. You can have quadriplegia at hand. You do this fixation, and believe me, a magic can be seen. And we have done over the years several patients where we have done fixation. And as I mentioned, there is an alternative way to do C1, C2 fixation by avoiding the C1 facet and removing the C2 spinous process muscles. So atlantoaxial and subaxial stabilization can revolutionize the treatment for cervical myelopathy related to OPLL. My answer to this question is absolutely yes. So over the years where we were doing only decompression for degenerative spine, I'm saying that only fixation is the treatment. So my concept is, my dear friends, I know I've gone a little bit beyond time. I know it is a little late for you. My concept is clear. My concept is definite. My concept is positive, and it is based on several hundred patients that compression is not the issue in spine surgery, and decompression is never the treatment. Thank you, my dear friend. Thank you, Yoko. And it is my great pleasure and honor to talk to African neurosurgeons. And I hope I have given some positive and new points for them to at least think about it. I'm not saying you follow them instantly. I'm not saying that they are the final word, but at least you can think about, at least you can go further on this issue, and maybe you get some newer ideas. Thank you very much, Yoko, and thank you, my dear African friend. Thank you.
Thank you so much, Professor. That was fantastic. Thank you so much. I render it over to Professor Abidasha to moderate this last session and to ask Professor Kato for closing remarks. Thank you so much.
Thank you, Dr. Kubolo. That was a fascinating presentation by Professor Goel. And we have seen his journey from craniovertebral junction to the subaxial spine with such fantastic clinical results with this alternative concept. And you have to see it to believe it. Does anyone have any questions?
Thank you very much.
I can see Sunjan Sharif. Yes, Professor Kato.
What? Oh, thanks, Satu. Thank you very much for your great lecture. So you always gave us some encouragement, and also you changed our concept about how we can think about the treatment of the spinal lesion, I think. So
thank you very much. Thank you.
Of course, daily we have so many patients who has OPLL or some, but I think you mentioned about the instability is a very, very important words, I think.
Thank you. Thank you, Yoko.
Thank you very much. Good friends.
Thank you, my great friend.
Thank you so much, Natu.
Thank you.
Thank you. Bye-bye.
Bye-bye. Okay.
Bye-bye.
Hello. So sorry. I would like to inform all our audiences that our next webinar, ACNS African webinar, will be tentatively to be held on 16th of March 2024. Thank you.
Thank you. Thank you.
Thank you, Prof.
Bye-bye. So, but I think...
Bye-bye. Thank you very much. Thank you.
Yes.
See you.
Can you give some closing remarks?
Yes, thank you so much, because many of the African colleagues, I think we should join for the next our webinar, and hope I think you can gain the knowledge, because the teachers taught you about their skills and knowledge, and also tips for many years experiences. I think you can learn a lot today. Thank you so much. Abida, thank you very much for, and also the Kavalo, thank you very much for your moderator today. Thank you so much.
Thank you very much. I think we can end this.
Thank you.
Thank you.
And see you.
Bye.
Thank you.
Bye. Bye.